All right, the Senate Committee on Public Safety will come to order. Good morning. In response to the COVID-19 emergency and to protect our public, the senators and Senate staff, we are limiting non-essential gatherings and adhering to social distancing. In compliance with these orders, the Senate will be holding an essential hearing and has made necessary adjustments to normal practices in order to ensure that the public continues to have access to the legislative process while we conduct the hearing in a way that protects the health and safety of the public and our employees. To allow for public access, we have admitted members of the public to the balcony and to a hearing room to the extent that social distancing requirements allow, and we will also be using a teleconference service for those individuals who wish to testify today. If you wish to provide public comment at the end of the hearing, there is a participant toll-free number and access code. It is posted on our Senate Public Safety Committee website, but I will announce it to you now. It is 844-291-6364, participant code 736-5485. When we move to public comment, a moderator will identify you individually, open your line, and at that time you may address the committee. Please note that in order for us to hear you clearly, you must mute the device you are watching the hearing on prior to giving your testimony over the phone. Thank you for your patience. While every effort has been made to streamline the hearing process and conduct our informational hearings as close to the same manner as is customary, there may be lag times for some participants adjusting to the use of the new online tools or technologies, and you never know when there can be just technological difficulties. Please be respectful and patient so that all interested parties can be heard. So we will now begin the bill hearing. I want to thank everyone for participating. In addition to our committee members, we welcome Senator McGuire, and on the Zoom will be Assembly Members Levine and Assembly Member Kalra. Let me open with some comments, and then I will ask if Senator Morlock or Senator Bradford would like to make any opening comments, which I hope can be brief, and then we will turn to Senator McGuire and Assembly Member Levine and Kalra in case they want to, but then we will go to our first panel. And I will mention what the panels are in a moment. So I'm Senator Nancy Skinner. I'm chair of the Senate Committee on Public Safety, and as I opened, this is a hearing on the spread of COVID-19 in our state prisons, a spread that is threatening the health and welfare not only of individuals who are incarcerated and held in our prisons, but also the staff, prison staff, and all Californians. A virus knows no boundaries. Its rapid spread has now infected a minimum of 5,000 incarcerated individuals, with over 1,100 in San Quentin alone, along with hundreds of staff who do not live in prison facilities but go home every day, potentially spreading the virus to family, friends, and our communities. As of today, the data we know from CDCR is 22 inmates have died, as well as 2 members of the staff. We know that California is currently experiencing record numbers of new cases, and we have pulled back on the planned opening of bars, gyms, and more. How much of the increase in cases is related to the uncontrolled spread in our prisons, which we know impacts our communities? Over the course of this month-long crisis, the governor, OES, and the Department of Public Health have held regular noon briefings guiding all of us on the importance of physical distancing, wearing facial coverings, hand washing, and the necessity to do widespread testing. What we have to ask ourselves now is, was the Department of Corrections listening? Was CDCR maintaining or mandating the same public health protocols that the state asked of the rest of us? Our state prisons are the largest congregate settings. The major outbreaks and the number of deaths from nursing homes told us loud and clear that congregate settings are incubators for a wildfire-like spread of this virus. My staff and I have been monitoring the outbreak in CDCR facilities since late March, early April. We've been in written and verbal contact with CDCR officials, the administration, the labor representatives of CDCR staff, and state public health professionals. And in the first 8 weeks or so of the outbreak, CDCR and the administration took numerous steps to limit the spread. They distributed masks, provided hand sanitizer, hand washing stations, stopped visitation and intake from county jails. And in those first few weeks, it appeared that the presence of the virus in the prisons was about the same as it was in communities throughout California. But at some point, things went terribly wrong. There was a growing outbreak initially at Chino, and then at the California Institution of Women, Chuckwalla, Avenal, followed by the horribly botched transfer of inmates from Chino to San Quentin. And as we know, there is now the presence of the virus in every single one of our state prison facilities. The decision to transfer incarcerated people from a prison with one of the worst outbreaks, Chino, to San Quentin, which at the point had no known cases, raises significant questions about CDCR's handling of this crisis. The now major outbreak at San Quentin threatens the incarcerated people and staff there, but also Bay Area hospitals and residents. Subsequent transfers from San Quentin to the correctional facility in Susanville, so this happened after the transfer from Chino, now has that facility with over 200 cases. And Susanville is the pipeline for our fire camps, and we are in fire season. The transfer of one incarcerated person to the Sacramento prison facility resulted in a nurse and a staff there who processed that individual, testing now positive. These and the original transfer raised legitimate concern and anger at CDCR's handling of the pandemic. According to the department, CDCR, in 2018, the 120,000 or so people that are held in our state prisons serve on average just 3.2 years. That's their average sentence. Now, thousands of those are being held in fear of death, in fear of permanent medical complications and injury from COVID-19, as well as I mentioned, the threat of spread, not only the threat, we know the spread in our communities. So incarcerated people and their families are legitimately and extremely worried about what will happen to them. CDCR staff and their families are legitimately and concerned about what is happening. The plain fact is, the virus is out of control at our state prison facilities, and it is defying every curve we point to for progress. And the plain fact is, our prisons are still overcrowded, and there are many hundreds of medically vulnerable and very elderly inmates who, as we know from the public health data, are at most at risk of death from this virus. The intention, at least my intention for today's hearing, is to hear from CDCR and the administration on the status of the outbreak, to hear what their plan is for containing the virus and reducing deaths, and for limiting community spread, and to hear what the plan is for identifying and accounting for staff infections, because the reported numbers seem very low, and to understand the testing process and how refusals for tests are being managed, and then to hear from CDCR staff representatives and advocates who are in communication with incarcerated individuals, as well as an external medical team that visited San Quentin. So the two panels we'll have, I'll introduce the panels in a moment. Let us just turn. Senator Morlock, do you have anything you'd like to open with?
Thank you, Madam President, or Madam Chair, excuse me. There was a recent television news report showing video of inmates intentionally spreading COVID-19. It would be interesting today to learn what was their assumption and why are they doing it intentionally. So when we hear the panelists, I'd like to see what's going on, but I echo your concerns and thank you for your opening remarks.
Thank you. Senator Bradford.
Thank you. Thank you, Madam Chair, and I think this is a critically important hearing, and not only for the safety of the men and women who work at these facilities, but the inmates themselves. And we have to be critically clear that the men and women who are incarcerated have not brought this disease into this facility. And we have to understand it's the men and women who work in this facility that go home on a daily basis who has brought this in. And I think it's critically important that these individuals are tested on a regular basis to not only, as your chairwoman stated, make sure that their family and friends are safe and unaffected by this disease, but more importantly, the men and women who are incarcerated who cannot leave these facilities. So I'm interested in hearing also from the leaders here at this facility on what they're doing to make sure that the men and women who work there are tested before they come to work on a daily basis.
Thank you. Senator Wiener.
Thank you, Madam Chair. And Madam Chair, I really want to thank you for convening this hearing, but also on your consistent leadership on this issue. And you have been deeply personally engaged on this, specifically around COVID-19 at CDCR for months now, and asking a lot of questions and pushing CDCR, and you have been on this from the beginning. And frankly, I wish that a lot of your advocacy had been heeded more over the last few months, because we perhaps could have avoided this fiasco at San Quentin and elsewhere. So thank you for your continued leadership. I think looking at the big picture here, tragically, what is happening, what we're seeing at San Quentin and elsewhere with the spread of this contagion should surprise no one. California has been on the leading, cutting edge of mass incarceration for decades, on the cutting edge in a bad way. This state has pioneered mass incarceration, going from 8 state prisons in the 70s to over 30 state prisons by the turn of the century. And despite that explosion in the number of prisons and the cost to our budget and the cost to so many communities, particularly communities of color being torn apart, our prisons were still dramatically overcrowded, and so dramatically overcrowded that the U.S. Supreme Court told us that it was unconstitutional. And so it is not shocking that with that level of mass incarceration and crowding in our prisons, it's not shocking that a contagion like COVID-19 would spread. And this is yet another reminder of the absolute imperative to reduce our prison populations and move towards decarceration. Mass incarceration does not improve public safety. It does not make us safer as a state, but it costs an enormous amount of money that could be going to health, education, and other needs, and it tears apart communities, and it has to stop. And this is yet another reminder to move aggressively toward decarceration. In the short run, we need to reduce prison populations at San Quentin and elsewhere to get a handle on this pandemic's impacts on our prisons, which, as the chair notes, will not stay contained to the prisons. And whatever happens in our prisons, there's a tendency to say that's just in prison. Prisons are linked to society, and whatever happens in prisons will spread out into the community, and vice versa. We are all in this together. And so I look forward to the hearing today to hear what CDCR is doing right now to dramatically change its approach around testing, around early release, making sure we're testing people as they're being released so that we are monitoring that situation so that we can get a handle on this. And then one related issue that I will be raising today, which I think is incredibly important, and that is, why is CDCR continuing to transfer people from its custody to ICE? Because when we transfer to ICE, we are sending people who may be medically vulnerable themselves to private prison ICE detention facilities. They're overwhelmingly run by private entities, where we believe that 1 in 3 of the detainees in those ICE facilities is COVID positive. These are COVID hotspots because the federal government has shown over and over again that it is either unwilling or unable to deal with this pandemic, and that it is unwilling to address the needs of immigrants. And we need to stop transferring people in the custody of our state prisons to ICE detention facilities. That needs to end immediately. Thank you, Madam Chair.
Thank you, Senator Wiener. Senator Mitchell.
Thank you very much, Madam Chair. First of all, let me echo the comments made by my colleagues in thanking you for your steadfast focus on this issue. And clearly that's what it's going to take in terms of not only appropriate oversight, but just making sure that we are fully aware and our constituents are fully aware of what's going on. You know, more than 15 years ago, as a result of Plata versus Schwarzenegger, the federal court determined that CDCR had failed to meet the basic constitutional rights of inmates with regard to access to healthcare services. So fast forward now to 2020, and we're still under the resulting receivership because we really haven't structurally fixed the problem. There are too many people in too confined a space with too few resources. And that brings us to the conversation today, where unfortunately none of us are surprised that COVID-19 has found its way deep into our prison system. And in my opinion, the situation currently at San Quentin is clearly just a canary in the coal mine. We will see, unless significant changes happen, prison after prison after prison. We already know that there are 1,000 cases at CIM in Chino. And so this is unfortunately just the tip of the iceberg unless drastic change happens. Many observers had noted some concerning practices in the system that conflict with advice from the WHO, the CDC, the county health director statewide. Practices like the transfers when there should have been sheltering, lack of communication with family and loved ones, and the discontinuation of programming. In other instances, maybe guidelines are being followed, as has been asserted by the department, and yet the disease continues to spread. Clearly, something is amiss. I, too, am eager to hear today what the plan of action is from this point going forward. As chair of the Joint Legislative Budget Committee, I'm keenly aware of the needs and requests of the department and will be using that lens in today's hearing. I look forward to participating, and thank you so much for convening us.
Thank you. Senator Jackson. Yes, thank you, Madam Chair, and also I share the same deep concern about the lack of oversight, the lack of caring and compassion that seems to exist in our prison system with respect to our prisoners there, with respect to their health care. As is noted by my good colleague from Los Angeles, we've been looking at this issue with CDCR for decades, whether it was women continuing to be sterilized in prison, whether it's the lack of concern for true rehabilitation. Our prison system, frankly, I think has failed us, and in no greater respect than what we're seeing now with this COVID situation. I have a federal prison in my district, the Lompoc Federal Penitentiary, which was, prior to San Quentin, the place with the greatest increase and surging of COVID-19 cases. The inability to get information, to be able to hold these people accountable. Of course, they're federal, so they really don't care much about what the state has to say about anything. But nonetheless, we see the same kind of lack of regard in our own CDCR system when it comes to how we treat these prisoners and how we address the seriousness of this problem. Whether there are people in prison who some might consider to be less than the rest of us, the fact of the matter is that these are people over whom we owe a responsibility. They are incarcerated. They have lost their freedom. And so we have a responsibility to care for them as human beings, and we are not doing that. So I will be very interested to hear what happens today as well. I am very frustrated with our federal system, which again does not think that they have any accountability to the people in our communities, and yet many of those guards and the staff and the people who work there have been exposed to this condition and brought it back into the local community. I think that that is part of the crisis that we're seeing, but the fact that there has been a complete and utter disregard for these inmates as human beings and the responsibilities that we have as a society to give people at least a very basic level of human dignity has really led to this problem today. And it is my hope that out of adversity,
comes opportunity, or as they say, out of lemons you try to make lemonade, that we can really start moving and advancing a more caring, a more just, and a fairer view of those we have incarcerated, those who, for whatever reasons, deserve to be isolated from the general population, but they should not be isolated from humanity. And that, I think, is what I hope we can address, or at least start addressing here today. Thank you, Madam Chair.
Thank you, Senator Jackson. We've heard from the committee members. It's 9:24. I'm going to turn to, we have some other senator and 2 assembly members who also want to make some initial comments, which I will turn over to them in just one moment, but I am indicating it's 9:24 because our first panel includes 2 representatives from the State Department of Public Health who I understand have a hard stop at 10. So since I know that many of us will have questions for them, I want to make sure that we give that panel adequate time. So now I will turn to Senator McGuire, followed by Assemblymember Levine, and then Assemblymember Colera.
Madam Chair, thank you. I want to take a moment to offer my appreciation, Madam Chair, to you and to your team for allowing me to be able to participate today. And I also want to say thank you to Senator Skinner, who's been leading from the front on this issue before it hit the headlines. She has been sounding the alarm for the last several months, and grateful for your leadership, Madam Chair. And again, I truly appreciate being here today. I also want to take a moment to say thank you to Secretary Diaz. He's been responsive to the needs in what I'm about to say. Obviously, I don't take lightly, and I am not one to typically go after state agencies, but here's my challenge. Represent the area where San Quentin is at. And I'm going to use a phrase that came from an epidemiologist in Marin County today. The conditions in San Quentin this morning have unstoppable momentum. Unstoppable momentum if the current conditions continue in the days to come. And again, I don't say this lightly, but this is a failure of leadership. This crisis is completely avoidable. The basic proactive actions that could have been initiated back in early June simply never happened to the level where success could be achieved. The 120 to 130 prisoners transferred from Chino should have never happened in such an old facility where there were no solid doors. No solid doors. And then the virus spread like wildfire. There is no proactive measures. We are leading behind the ball. There are staffing shortages, lack of cleaning protocols, not enough security now at hospitals, lack of communication with public health agencies in both the County of Marin and County of San Francisco. Physicians are now spending hours upon hours to find hospital beds to transfer inmates out to. There is insufficient custody staffing. And tonight we'll have our follow-up meeting with, we'll call it an all-hands-on-deck meeting between the legislature, CDCR, San Francisco Public Health, Marin Public Health, along with the governor's office. We need to develop a unified incident command on site. Bottom line, all agencies involved are hearing the same thing all at once. We need to develop a strategy to create surge capacity for ICU and hospital beds in the greater Bay Area. As of 10 p.m. last night, 24 out of 25 ICU beds in Marin are full. 8 are San Quentin inmates. We need to create EMS protocols for patient transfers so that we're not flooding one area of the Bay, but there is a strategy to be able to transfer. There is going to need to be some type of on-site medical facility established. We need to discuss what that strategy is for planned early release and where those individuals will potentially be quarantined. And there has to be a long-term decision on additional transfers into the facility. Madam Chair, thank you for allowing me to be here. Thank you for the opening comments, and truly, Senator Skinner, thank you for your leadership on this issue.
Thank you, Senator McGuire. Before I turn to Assemblymember Levine, I appreciate your clarity on things they need to do, and I have no quarrel with it, except that I do not think it will be adequate if it is done at San Quentin alone. We do not know the extent of this virus now in all the rest of the facilities except what is reported. We know that everyone has not been tested. We know that all guards have not, just staff, I should say staff, have not been tested. So I think that while you have outlined a plan for one facility, this must be a plan for the entire system. Assemblymember Levine.
Thank you, Madam Chair, for your invitation to participate in the opening comments of this hearing. This is extraordinary, as I'm not a member of the committee, nor am I a member of this House. This is a hearing of consequence that weighs heavily on my constituents who hear the sirens of ambulances. We are grateful for your steadfast leadership on this issue. COVID-19 is a dangerously powerful force of nature, but human behavior can control its spread. Advocates for Californians who are incarcerated raise the need to prepare and defend those in custody from the virus early in the pandemic. I heard their concerns and those of Marin County's Public Health Officer, Dr. Matt Willis, about the alarming potential of an outbreak of COVID in our prisons. So I acted. I wrote letters and spoke with the leadership of CDCR. I spoke to this issue during the Assembly's Committee of the Whole budget discussion with the Governor's Director of Finance. I spoke with members of the Governor's Cabinet. I spoke with the Governor. I called upon CDCR to create site-specific COVID plans for each of its facilities. I called for an expert in epidemiology or public health to be in a position of decision-making authority at CDCR after the disastrous transfer of inmates to San Quentin. That was nothing more than the worst prison health screw-up in state history. Yeah. We did not meet this moment. I called for a plan for hospitalization so that hospitals would not be crippled by both community spread, as we are seeing in Imperial Valley, and a surge of infection at prisons like at San Quentin that has now claimed over 1,200 victims in less than a month. I called for an incident command to be set up. I asked for a plan. What we received was unacceptable, unmitigated disaster delivered by a lack of planning and preparation. We cannot sweep it under the rug. There must be accountability. Whatever is said today won't make up for lost time. It won't ease the pain of the afflicted staff and prisoners. We can't go backward. We will be presented a plan today. Never has too little too late been more true or cruel. Never has better late than never been so morally repugnant. Thank you, Madam Chair.
Thank you, Assemblymember Levine. Assemblymember Kalra.
Thank you, Senator Skinner, for your leadership. I appreciate you and everything you've done. I appreciate the comments from my colleagues, and I agree with pretty much everything that's been said by our colleagues. And I just want, I don't want to take too much time so we can get to the panelists, but I do want to make it clear that we need to be guided by public health. That's what the message has been throughout this whole crisis. And yet, those that have been in prison and the CDCR, I mean, they have not been guided by that public health, or at least the indications aren't such. And so we need to make sure that we're doing everything we can to protect the incarcerated, protect those that work in there. And let's think about whether if that was your family member that was incarcerated, if that was your family member having to go in there to work, what kind of environment would you want? And so what I want to hear, I would like to hear is, what are the public health recommendations? How is the prison, are the prisons complying with them? How far away are they from complying with them? What needs to be done? What do they need from us to make sure they get there? I also agree with the comments from colleagues. I think all ICE transfers, or at least informing ICE, that's an internal policy that needs to stop immediately. And I think finally, we need to get releases and figure out how we can release. I know that the administration had worked on that in the first iteration, and I'm grateful for that. But now we need an expanded criteria for release. I know that 180 days has been used. We have to expand that, and even if it's on a case-by-case basis, get people out if they don't have housing, use Project Room Key or any other mechanism available that we've created through this COVID crisis, and get individuals out of that environment, because that is truly the best solution to minimize the risk. And so I appreciate this hearing, and I look forward to the panelists. Thank you.
Thank you, Assemblymember Carra. So we have, yes, Senator Mitchell.
Pardon me, Madam Chairwoman, just a point of clarification. You said that there was a hard stop at 10 for everyone on the
No,
panel or just the
for
Public Health Department?
Officials, the public health officials.
Say it one more time.
Just for the Department of Public Health officials.
Thank you very much, because I was going to say I felt that's wholly inadequate given the severity of the issue and the nature of the questions we have. Thank you.
You're welcome, Senator Mitchell. So we are going to have two panels. I will introduce the second panel later just because we're running out of time. The first panel, we will hear from the administration and CDCR. It will include Secretary Ralph Diaz Secretary of CDCR. It will have Clark Kelso, who's the federal receiver and who is ordered by the judge to oversee the delivery of health care in our prison systems. Mark Galley has now not available, so we will also hear from Susan Finelli, who's the Chief Deputy Director of Policy and Programs at the Department of Public Health. So I'm going to start with Susan Finelli, but no, she's not available yet. She hasn't joined yet. Okay, I know she has to leave at 10, so I'll start then with Secretary Diaz. But Secretary Diaz, I'm sure there's much we will want to ask you and talk to you about, so I need you to stay on, but I may switch to Susan Finelli before we are really completed. And Secretary Diaz, before you start, you know, the Senate went out in sometime in March, and of course we were home. And while I was home, I watched with horror what was occurring at Rikers and at a prison in Ohio, and then at some federal facilities. And I saw COVID spreading like wildfire at those facilities. And I thought about our state prisons. And so we started regular calls. And I wrote my first formal letter to you and the administration in April, basically asking for what is CDCR going to do to avoid what happened in Ohio in Rikers. And I just feel like it was not taken seriously. And that while the rest of our state was getting clear messages and people were being protected, that was not the case with our folks who are in the system. And so you may open, and I'm sure members have many questions. Secretary Diaz, and thank you very much for participating.
Thank you, Madam Chair, and members, if you don't mind, Madam Chair, I have a statement to read.
Okay.
So I want to thank you for the opportunity today to talk about the California Department of Corrections and the efforts to mitigate COVID-19 in our facilities. We understand and share the concerns for the incarcerated population and staff, and we've become heightened in our awareness since the beginning of this worldwide pandemic. Protecting the health and safety of all individuals in our institution has always been and will remain a top priority. Since before the global coronavirus hit our community, CDCR and CCHCS, the receiver's office, have worked tirelessly to implement measures to protect staff, incarcerated population, and the community at large. CDCR and CCHCS took immediate steps to implement strategies to halt the spread of COVID in accordance with CDC and CDPH guidelines. These efforts have been done in coordination with Mr. Kelso and the receiver's office and his team, and based on public health input and guidance. Knowing that COVID-19 would reach our institutions from the community, we began by suspending visitation and tours statewide. We suspended in-person observers at parole suitability hearings and halted all construction projects within the perimeters of the institutions. We began verbally screening all who entered the institutions and expanded the screening to include temperature screening at all institutions. Recognizing that prevention was a key, we also delivered fact sheets and posters to educate inmates and the population and staff. We instructed all institutions to order hand sanitizers and to be placed inside the institution's dining halls, work areas, and housing units. We increased the frequency of disinfecting and deep cleaning efforts in high traffic areas, high volume areas such as day rooms, dining halls, showers, and restrooms. Working closely with the California Prison Industry Authority, we began producing cloth barrier masks, which we distributed to institutions for the use of staff and inmates. Once masks had been distributed throughout the institutions, the use of masks by inmates and staff became mandatory, and it continues to be mandatory. Acknowledging the importance of physical distancing and preventing the spread of the COVID-19, we activated gymnasiums, vacant housing units within institutions to move thousands of inmates from dormitory-style housings to spaces where we could increase physical distancing to 6 feet in all directions, and we attempted to achieve this. We modified our programming. We also suspended intake from county jails, expedited the release of approximately 3,500 incarcerated persons in April. CDCR reduced the incarcerated population by more than 8,000 since mid-March. We intended to further reduce the population by implementing rolling early releases starting this week and next week. This is a statewide effort. Understanding the concern of the family and loved ones, we established a website and dedicated email addresses to keep them informed. In recognition of the need of the incarcerated people to have contact with their loved ones, we also partnered with our phone contractors to provide free phone calls each month and expanded phone access to certain privileged groups that otherwise would not have them. Thanks to the partnership with local health departments and with the help of the statewide testing task force, we have performed mandatory staff testing at 12 institutions, and we've tested approximately 13,200 staff. There are still more tests pending with these results, and they're ongoing even as we speak. But as you see from the public tracker, there have been 847 positive staff cases. We've begun rigorous staff testing plan at 4 institutions that are subject to the CDPH skilled nursing facility guidelines. This includes baseline testing for all staff by June 30th, which has already happened, and will require serial testing on a weekly basis until there are multiple testing events with no positive cases. In addition to the partnership with CDPH and the Health and Human Services Agency, CDCR is moving forward to a non-skilled nursing testing plan that provides for weekly serial testing of staff at institutions where there is an outbreak. Such is the case at St. Quentin. We're rolling out a statewide testing plan to provide for the frequency of this outbreak in institutions and baseline and future surveillance testing for all other institutions starting today. With 65,000 staff spreading throughout every corner of California, it's been a challenge to find a vendor with sufficient capacity, but we are moving forward aggressively. So while we have developed comprehensive strategies to respond to COVID-19 to minimize the spread of the virus still continues to spread in our facilities, just as cited by all the speakers and you, Madam. We have had setbacks, such as the San Quentin outbreak, but we remain steadfast in our response and dedication to meeting the moment to protect our population and the staff in the community. CDCR is taking further action to mitigate the outbreak at San Quentin. These actions include establishing a unified command center at the prison to coordinate custody and medical response. The team is comprised of medical, custody, emergency management, and infectious disease experts from CDCR and CCHCS, the Governor's Office of Emergency Services, Emergency Medical Services Authority, California Department of Public Health, and Division of Occupational Safety and Health. Additionally, the prison is currently installing 6 tents that will be used as an alternative care station to treat COVID-19 inmate patients on grounds, and that opens up certain areas of the prison to allow for increased physical distancing, quarantine, and isolation, to include a gymnasium at that institution. I need to express, though, we can do better, and I know we will do better, but I need to express we've also had successes. There are 16 of our institutions that have remained COVID-free to date, despite rising cases in surrounding communities, with the additional 8 reporting only single-digit numbers. We have curbed the outbreaks of several other institutions, including the California State Prison in Lancaster and the California Institution for Women. This positive progress highlights CDCR and the Receiver's Office's isolation and quarantine efforts. The mass testing implemented immediately after the first COVID-19 case was confirmed has helped mitigate the spread of the virus. CDCR and the Receiver's Office, we are working around the clock to fight COVID at all institutions. We are part of this community. We each step in and we have to take our place in furthering the goals of public safety and public health for all. We'll continue to look forward to ways to improve our efforts in every single way possible, which includes the invitation for continued productive collaboration with our valued stakeholders. Now, I will say, I know I'm going to have a lot of questions right now, but one thing that I did hear was the lack of care. Or there's a thought that that the Department of Corrections or myself do not care about the population, or we view them as subhuman, or they don't deserve the same types of considerations as all of us are, and that all of us receive out here. I couldn't say that's the farthest from the truth. We have worked tirelessly to change the culture in our institutions. We have dedicated staff members returning to work to the tune right now of 370 staff members have returned to work to do the work of assisting and mitigating and helping out and reducing this COVID. So the thought that we don't care, or I don't care personally, that's the farthest from the truth. We care about the inmates. We care about the staff. Could we have done better in many instances? And I'm going to answer some of your questions. Of course we can. But we are 4 months into a pandemic, 4 months into a worldwide pandemic that we are leaning and leaning into as many resources as possible. And the receiver's office and CDCR have been working arm in arm to try and mitigate at all institutions, not just San Quentin, but right now San Quentin is a priority. So with that, Madam Chair, I'll take your questions.
Thank you, Secretary. I think that we are going to hold on the questions to you and hear from Dr. Gali, because I've just learned that he has joined us. So if I could turn to Dr. Gali, who's the Secretary of the California Health and Human Service Agency and who's been directing California's public health response to the pandemic. Dr. Gali. Is he not available? Oh, so Dr. Gali, you need to unmute yourself. We can't hear you. You need to be unmuted.
Okay, are you able to hear me now?
Yes, now we can. Yes, go ahead.
Beautiful, thank you. Chairwoman, thank you. Committee, I have limited time, but I am appreciative of having a chance to join this hearing, this very important hearing on what I think is an essential and important issue across our state. I want to thank Secretary Diaz for his partnership over the last many months that really began back in March as we began to see the threat within our prison system, just as we, through HHS, our departments, primarily CDPH, as well as EMSA, to be able to partner with CDCR in order to ensure that protocols and plans around infection control and testing are rolled out. I want to begin by also saying that today our focus is on the issues at San Quentin moving forward, ensuring that as we continue to provide some support to Secretary Diaz and the receiver and their respective teams at the facility and beyond, that we look forward to instituting many of the things that were mentioned by the committee members and by Secretary Diaz in terms of infection control, in terms of incident command, in terms of modeling what we expect to see, not just in San Quentin, but in other CDCR facilities, ensuring that the testing supplies and processes and labs are available so that we don't have further delays in testing that could be done, ensuring that assets such as staff, tents for on-site, on-property, additional housing units are available so that we can do 4 primary things. Ensure, and I will share that through years of experience before coming to the state, both managing and overseeing medical services, both in Los Angeles County's juvenile detention facilities and at the largest jail system in the nation. This comes from a number of years of experience running those jail facilities and the medical services there. That in a pandemic or in any outbreak, the first issue is to identify those who are sick versus not sick. And among those who are not sick, we must know who are infected and who are not, and effectively cohort them in distinct areas served by distinct staff and limiting movement and mixing as much as possible. Because if we haven't controlled the entry of the virus or the infection through the front door, the job number one is to make sure containment happens in the facility in a successful way. Once you've identified safe and infection control procedures for those who are not sick, it's important to monitor those who are known to be infected yet not sick, and then also ensure that we continue to test and track those who are not yet infected to ensure that if they do become infected, we pay close attention. For those who are sick, we obviously want to make sure that those who need the acute high-level care are transferred safely and immediately to outside facilities to receive that level of care. I think the plans that are in place moving forward to work with the community hospital system, the local public health departments, not just in Marin and San Francisco, but also in other counties across the Bay where hospitals may be accepting patients, to work through the regional coordinating system and our EMSA system led by Dr. Dave Duncan, who he himself has helped manage the transfer of patients in Imperial County to various outlying and out-of-county facilities. The same can and I know is planned to be done now in the San Quentin case. This requires close connection with Dr. Willis and his team at the Marin Public Health Department, and in particular, close work with Marin General Hospital and ensuring that that hospital has capability not just to serve the San Quentin patients, but as Assemblyman Levine mentioned, ensuring that there's adequate capacity for the Marin community as well. Furthermore, part of what Secretary Diaz mentioned through close and connected work with Director Ghilarducci at Cal OES, ensuring that we have the ability to bring additional space to treatment capability and space to San Quentin to ensure those who are showing early signs and symptoms or moderate to mild signs and symptoms can be adequately cared for on the facility with strong medical personnel, correct equipment and medicines in order to make sure that if they can avoid going to the outside facilities, that we're able to do that in a safe and meaningful way. That, of course, ensures that those who need the higher level of care have adequate access to those services, both within the prison system and within the community at large. Although this is an unprecedented situation, the rules and lessons we've learned from prior outbreaks in prisons and correctional institutions hold true today in this setting. And I just want to underscore, before I turn it back to you, Chairwoman, what you said. This is not just a San Quentin issue. We must continue to learn the lessons in this evolving pandemic and ensure that we not only take those into account at San Quentin, but all of the facilities and my entire agency and our departments continue to stand ready to serve and partner with Secretary Diaz and all of the members of this committee to ensure that we put our best foot forward for a very vulnerable population.
Thank you, Secretary Galley. Committee members, what I would like to do is, since he has limited time and must leave at 10, I would like to direct some questions to him before we turn to other panelists and before we direct our questions to the rest of the panelists. And I would like to start with one. So, Dr. Galley, in the noon briefings with the governor, you and the governor have pointed many times to a curve, and you have used that curve to guide the rest of us in relationship to how to respond throughout the state of California. Was such curve analysis done for CDCR facilities? And if it wasn't done in the past, are you doing one now?
It has not been done, and in part, many of those models and curves require us to have accurate information about the level of infective spread, what we talk about as the R effective, and we can certainly create that and have at least internal conversations around how to create that, not just system-wide, but it would be needed to occur across any facility. And what it would require us to do is both understand the level of how close inmates are to one another. Obviously, the level of adherence and use of personal protective equipment and physical distancing as much as possible, because all of those elements go into designing one of those curves. It is generally created for large communities where there is general freedom of movement and mixing, and takes into account some of the non-pharmaceutical interventions that we've been discussing, including face coverings, N95s, and other PPE, as well as physical distancing. I think the important issue to know that as one of the most important efforts is making sure that our collaborative plan for testing, and Secretary Diaz, I know, is working hard along with our teams to ensure that that testing is available to staff, the receiver to making sure that's available to all inmates, will be exactly the type of information and that test positivity rate that will allow us to build those models for all of the facilities.
Thank you. Dr. Ghali, I have to say, though, I do not feel that's a satisfactory answer, in that this is a population that's in custody, and the people that deal with them are staff of the state. So this is a population that we control, both the staff in it and the people. And so the testing could have been done, and could have been mandated. The wearing of masks could have been mandated. All of the things that our counties are telling the rest of us. This is an entity that is even more conducive to such things just because of the nature of the control we have over the individuals. So it's, I don't feel very satisfied with the answer. And I would say that to both CDCR and the administration, I started raising the question of testing back in early April. And I know that California did not have adequate access to tests, but as we watched the outbreak in nursing homes, and we knew that, and we began to notice, not notice, but learn the spread by people that were not symptomatic, this testing really, really was necessary in this largest congregate facility. And apologies, I should stop expressing frustration and let my committee members also ask questions. Senator Morlock.
Senator, may I just comment, one brief comment? I want to make sure to separate out the answer around the modeling, which is something that should and can be done, and it requires us to build in all of the information I mentioned. I think I really do want to emphasize that the plan around testing and the recommendations around testing were ones that have been made. We've been partnering on ensuring that those tests get done at the scale, and Secretary Diaz mentioned a significant number of tests. Is that enough? Is there more to do? Absolutely. And I am the first to say that the global testing challenge in California was, really has multiple factors, but at the end of the day, we take serious responsibility to starting out with not enough testing, not just in our congregate care settings or those that are run by the state, but statewide. And today we have really raised up, started from just about 2,000 tests a day back in April to today, achieving over 100,000 tests on some days. So it means to me, and the message to all of you is that testing is possible in many of our facilities, and it's ramping up. So that should become something that allows us more intelligence into the situations, into the facilities, and allows us to plan better. There is no dispute that more could be and should be done. So I would hesitate to leave the committee with the impression that I or any of us believe that the response has been satisfactory and that more should and can be done.
Thank you. Senator Morlock.
Thank you, Madam Chair, and thank you, Dr. Ghali, for dealing with this crisis management situation. We're dealing with constituents, and they appear to perceive and they're observing that we're neglecting nursing homes and prisons and all they see is being told to close beaches and rent arenas that aren't used. So we're trying to figure out how to communicate to our constituents, and how can I best tell them how you select priorities?
Dr. Gawley, you're muted again. We still can't hear you. Okay. Now I think you're unmuted. Go ahead.
Can you hear us now?
Yes,
okay.
yes, yes.
Seems like each time we have to unmute, so
Yeah,
we'll
sorry.
try to be quicker doing that. I think it's a very important question, and the issue in congregate care facilities is clearly the front door is where the infection comes in. And based on the level of mixing between staff and residents, whether those are inmates or residents in a skilled nursing facility, we begin to see a very rapid spread rate. So our number one strategy is to ensure that in any congregate care facility that we prevent infection coming into the front door. I will say, Senator Morlock, that we have had a number of success stories within some of the congregate care facilities wherein we might have even had a large outbreak in the setting, but have through some very thoughtful, tried and true, frankly, infection control strategies, been able to separate staff, separate residents or inmates, and allow, hopefully without significant consequence in terms of illness and death, the outbreak to settle down, and then institute the serial testing and surveillance testing to protect further outbreaks. We've done that in a number of facilities, not just in the skilled nursing setting, but assisted living setting. I know Secretary Diaz has similar stories, so it can certainly be done and has been done. I would say that part of what we see absolutely is as community spread increases. So the current wave of increased cases across our communities are early indicators of the spread that we will again see in some of our congregate care facilities. So with this increase in community spread, we have and will continue to increase our own vigilance in some of those congregate care facilities. The other point of importance is our congregate care facilities, whether they're jails or prisons or nursing homes or other settings, tend to have some of our most vulnerable populations from a healthcare perspective. The number of comorbidities and pent-up medical need within populations in the justice system, whether at the local level or the state level, is extremely high compared to our communities, our not in congregate setting communities, and that does play an important role to the level of vulnerability around COVID-19. We continue to refine our understanding of which underlying conditions lend themselves to the worst outcomes. The CDC, in fact, just updated over the weekend the list of tiered conditions that seem to have the highest risk to bad outcomes with COVID-19, and the state looks at that and updates our own guidance accordingly.
Thank you, Dr. Gawley. Just a quick question. Since we don't have any background materials for this hearing, there are two things I'd like to understand or have some data provided. One is, what is the flu statistics? How many deaths do we see in prisons year over year? So do we have anything that's abnormal or above the trend? And the second is, how is California and its prison system doing compared to the other 49 states? Are our per capita numbers similar, above, or below? So if you have that information now, that'd be great, but otherwise I'd like to see it just to at least analyze how we're doing year over year and state by state. Thank you.
Yeah, I don't have it today, but we'll work with CDPH as well as our other colleagues on this panel to get you that information soon.
Thank you, Madam Chair.
You're welcome, Senator Morlock. Dr. Gawley, before you are no longer able to stay with us, I have a question. The courts put our prisons under receivership. We have a receiver now for that health, but that receiver has also, over time, turned certain facilities, about half the facilities, back over to CDCR. So it's my understanding in that process that about half of the facilities are still under the receiver and another half are not. Now, the receiver, when we hear from him, may indicate he still has responsibility for the whole system. I don't know, but it seems to me that that this is obviously a system-wide problem and that it needs competent public health medical professionals, whether epidemiologists or others, to be calling the shots as to what happens and developing a plan. So I'd like to know from the Department of Public Health whether such personnel will be designated to oversee this, how we respond to this outbreak and to containing it and also to reducing the number of deaths.
Thank you again for the question. I'm going to let Susan Finelli answer most of that question, but I will say that Secretary Diaz mentioned our activation of the incident command team, which will include expertise at the highest level around epidemiology and tracking the disease, infection control, and those supports are available and coming to bear on that team.
And is that incident command only for San Quentin or for the entire system?
This initial incident command team is for San Quentin, but I know Secretary Diaz has shared a plan and vision for extending that, and we are ready to partner and provide the resources that we can and need so the response is adequate. I think we as an agency continue to stand ready to provide both guidance and assistance in any way that we can. And if it requires us ourselves to bring on additional staff, we will do what we can as speedy as we can to do that because we understand the gravity of the situation. And as I've said in other press conferences and other hearings, that this is a virus that goes in tight quarters from 0 to 60 very quickly. We see that by the time you actually have a chance to test everyone, that a number of people are infected and that we have to do what I started this sort of my brief comments with in terms of separating out those who are infected and those who are not and continuing to test. So we stand ready to continue to support Secretary Diaz and the receiver in any way that is needed, and of course to add our expertise through providing guidance in an ongoing way. I appreciate a chance to provide some brief comments, and if there are further questions for me, I can be reached directly or through staff, and I'd be honored to provide as much information as I can down the road. Thank you.
Thank you for participating and providing us the information you have, and I'm sure we will have additional questions. What I'd like to do now, members, is turn to Susan Finelli, and then we will hear from the receiver. And then we can open questions to all, to the Deputy Director of Policy and Programs for the Department of Public Health, to the receiver, and also to Secretary Diaz. So let's turn now to Susan Finelli.
Good morning, and thank you for inviting us to participate in the hearing. My name is Susan Finelli, and I'm the Chief Deputy for Policy and Programs in the Department of Public Health. I was asked to give a little context. Nationally, there are 2.6 million COVID cases and total deaths of 126,739. We now in California have over 222,000 cases, with new cases climbing each day, and resulting in a total of, in the last 24 hours, the number of COVID-related cases increased by 2.9% and deaths increased by 0.7%. So clearly a problem throughout California. California's hospitalizations have increased yesterday by 300 cases for a total of positive hospitalizations of 5,077. That's an increase of 6.3%. At the beginning of February, most cases of COVID-19 were in returning travelers. The first recognized community transmission was identified in late February. In early March, case numbers began to increase, and on March 4th, the governor declared a state of emergency in California. As the number of cases began to increase, the governor implemented a statewide stay-at-home order on March 19th. During the initial phase of the pandemic, testing was extremely limited. Initially, testing was only available at the CDC. Testing became available in public health labs in late February and subsequently was available in commercial laboratories. Testing was prioritized initially for only symptomatic persons and persons exposed in high-risk settings, particularly healthcare workers. Testing resources were not available for baseline testing or widespread use in correctional facilities until later. The first 500,000 tests were conducted over approximately 2 months through late April. The pace of testing has increased rapidly thereafter. The number of COVID diagnostic test results in California have now reached a cumulative total of over 4 million, an increase of about 100,000 tests a day since each day. The rate of positive tests over the last 14 days is 5.6%, and the positivity over the last 7 days is 5.9%. So you can see that that is climbing. As testing capacity has increased, opportunities for deploying this testing to control disease in congregate settings has increased as well. We continue to learn about the transmission of this very infectious virus, which is hard to contain in any environment, but very challenging in congregate settings. The primary goals, as Dr. Galley went over, are to prevent the virus from entering the facility and to aggressively work to reduce transmission when a case or cases are identified. Infection control measures will not stop all infections, as many staff and inmates may already be exposed and may develop symptoms over a period of the next 10 to 14 days once the first cases are recognized. Recommendations to test aggressively will result in the growth of the number of cases, as asymptomatic cases will be identified through that testing. CDPH has been providing guidance to the California Department of Corrections and Rehabilitation and CCHCS throughout the pandemic. The Department of Public Health serves as a technical consultant to CDCR and the receiver for state prison outbreaks across the state. Early in the pandemic, we assisted in the development of a general guidance document posted on the CDCR website and provided follow-up guidance on outbreak control. We have participated in numerous meetings and provided verbal and written guidance on specific prison situations. We do have dedicated staff that help with this technical assistance. And even though we have some standardized guidance, we recognize that given the layout of the prison, the general age and health of the inmates in a particular prison, the availability of staff, and the provision of PPE and any operational challenges make it necessary to have individual plans. When cases and employees or inmates have been identified, CDPH has provided verbal guidance on that situation and has been tracking cases, and CDCR has been tracking those cases and employees and providing data on their website. Testing shortages were a problem across the state and nation early on, so CDPH worked very hard to develop the testing plan, providing options for matching available laboratory resources for both specimen collection and conducting laboratory tests to the needs of prisons across the state. Even with expanded testing, facilities sometimes face longer than ideal turnaround times and allowing them to better manage the situation. More recently, we assisted in providing an overall testing strategy similar to the strategies employed by skilled nursing facilities, including both surveillance testing in prisons with no outbreaks to require baseline testing over each week and more aggressive serial testing of staff in facilities with outbreaks. Surveillance testing of non-positive facilities allows for the early cohorting of these asymptomatic positive cases and allows for facilities to appropriately cohort inmates and also limit the movement of staff in the facilities. In addition, we've worked to develop a more detailed infection control guidance with very specific recommendations that are adapted for the needs of each prison. This guidance provides strategies for preventing staff from introducing the virus within the facility and an aggressive approach to containing the spread of the disease. These strategies include prevention and control interventions, including monitoring of all staff and inmates for signs and symptoms, universal masking by staff and inmates for source control, use of recommended personal protective equipment, maintaining appropriate physical distancing, and environmental cleaning and disinfection. CDPH has been on the ground working with CDCR and receiver, particularly at the Los Angeles County, Koala, Avenal in Kings County, California Institute for Men, and San Quentin. The control of COVID-19 in prisons depends on many strategies: minimizing visitation and non-essential movement from outside the prison, screen employees and anyone entering the prison, sequestering inmates for 14 days, and ensuring that employees working with sequestered inmates do not work within the other parts of the prison, excluding any and all ill employees, practicing social distancing, wearing masks, and practicing safe hand hygiene for all staff and inmates, canceling non-essential gatherings, limiting the movement of employees between different work areas, quarantining exposed inmates for 14 days, isolating infected inmates, testing and excluding exposed staff from work, and a host of other strategies that we've been laying out since the beginning of the pandemic. Some of these strategies are difficult to accomplish while balancing the needs of operating a prison given staffing shortages, space constraints, and other operational needs. As Dr. Ghali and others have mentioned, we are taking a much more aggressive stand in the coming together for the situation in San Quentin, establishing that incident management team to coordinate patient care and movement, as well as to make sure all of these infection and prevention strategies are in place. We continue to recognize this challenge in both in all congregate settings, but primarily in skilled nursing facilities and prisons. And we are here to partner, and we continue to have dedicated staff to this effort and are happy to not only play the role of technical consultant, but to be part of these incident management teams.
Thank you, Ms. Finelli. I will note that the visitation stopped. CDCR ended visitation at all facilities before April 1st. Additionally, many of the things you described were, at least by the department's own indications, implemented, and yet many were not. But yet we have the situation we have today. So how thoroughly these were implemented. But I would say that the movement of the administration themselves stopped the transfer from county jails, the visitation was stopped, all of those things were done. Anyway, let's now turn to Clark Kelso, who is the federal receiver for our state prison system, California Correctional Health Care Services. Mr. Kelso.
Good morning, Madam Chair and members. My name is Clark Kelso. I serve as the federal receiver responsible for medical care within CDCR. I was appointed to this position by the federal court in the class action litigation Plata versus Schwarzenegger in 2008 and was charged with bringing the level of medical care up to constitutional standards. As receiver, I exercise all of the powers that Secretary Diaz possesses, but with respect only to the department's medical care system. That's why both Secretary Diaz and I are here today. A significant amount of progress has been made in improving CDCR's overall healthcare system, which has contributed to our capacity to respond to the COVID risk. And I have delegated back to the state, Madam Chair, as you noted, the management of 19 of its 35 institutions, which is a presumptive indicator that those institutions are delivering a constitutional level of care. COVID, of course, is a new and system-wide challenge, and so I work most closely with Secretary Diaz and Undersecretary for Healthcare Diana Tosh on COVID matters. Faced with the crisis of COVID, our collaboration has never been closer. I'd like to give you an overview of our planning and efforts to combat COVID-19 over the last 4 months, some comments on the crisis at San Quentin, and a brief status report, and then, of course, take questions. Planning, as you've heard, began in late February. As you know, CDCR essentially operates the largest congregate living facilities in the state, which are perfect facilities for the spread of communicable diseases. So on March 11, CDCR's public health branch issued its first COVID guidance to the institutions, based in part and including links to guidance published by the Centers for Disease Control, California Department of Public Health, and the California Occupational Safety and Health Administration. And we began posting that guidance on our intranet pages. We also released our public-facing internet sites that contain the COVID tracker for the prisons, CDCR's COVID preparedness pages, and healthcare's interim guidance. The interim guidance is particularly important for our institutions because it has the basics to combat an outbreak, including directions on testing, isolation, contact tracing, quarantine, monitoring, hospital referrals, everything that Dr. Galley has mentioned. 2 days later, on March 13, Secretary Diaz and I sent out our first communication to all CDCR employees to begin reorienting everyone to the challenges that were come. And our first case occurred only 1 week later, on March 20th, at CIM, the California Institution for Med. Now, during March and April, as you have heard, CDCR took a series of important steps, including establishing an overall COVID-19 coordinator, standing up the department's operations center, sending out guidance for facility entrance screening for all staff, implementing an accelerated release program, imposing severe restrictions on intra-facility movement, shutting down visitations, halting all non-essential transfers between prisons, and closing CDCR to intake. The number of cases at CIM grew slowly during April, but cases spiked on May 1st, jumping from 91 to 218. And the number of cases continued climbing, reaching a high of 475 by May 15th. As a result, during the first 3 weeks of May, we considered whether we could safely move a large number of those vulnerable patients, the negatives, to another facility with the goal of saving lives. The decision involved a balancing of the growing risks to the CIM patients against the risks of any large-scale transfer. We were also considering in May how the department could slowly begin reopening and reestablishing some of its normal processes. And on May 22, a memorandum was distributed to the field announcing CDCR's phased approach, which included a slow reopening of intake and the resumption of inter-institution movement. Attached to that memorandum was a COVID screening and testing matrix for patient movement. The matrix provided, among other things, that a transferring patient should receive a COVID test, that a patient could transfer only if the test was negative, and then no individual should be transferred to another institution prior to the availability of their test results. On or about May 23rd, we decided that the expanding cases at CIM posed an unacceptable risk to the last remaining dorm where hundreds of COVID high-risk patients were housed. And the decision was taken to move those patients out of CIM. Some were moved to Corcoran and the remainder were moved to San Quentin. Because the matrix did not specify that the required negative COVID test had to occur within only a short period of time in relation to the transfer, such as 7 days or less, when the moves were made out of CIM, although all patients had negative test results, in many cases, the tests were 2, 3, and in some cases, 4 weeks old. Far too old to be a reliable indicator for the absence of COVID. As it turned out, 2 of the 66 patients moved to Corcoran tested positive when they were retested at Corcoran. The rest were negative. Corcoran has been managing their outbreak pretty well so far. They have 125 cases active, 30 cases have already resolved, and they have had 47 of the 125 cases in the last 14 days. They've sent out to the hospital only 1 patient. San Quentin, of course, has been a very different story and is in crisis. Upon retesting at San Quentin, 25 out of 122 transferees tested positive, and San Quentin almost immediately fell behind the virus. On June 12, I asked Dr. Bree Williams from the University of California at San Francisco and Dr. Steph Bertozzi from the UC Berkeley School of Public Health to conduct an in-person assessment. They visited the prison the next day on June 13 and reported serious resource deficiencies in the physical plant, in COVID support staffing, and in testing. The following deficiencies, most of which were identified in their report, materially contributed to the rapid spread of COVID at San Quentin. First, the 5-tier cell blocks lack good ventilation and have virus spread characteristics similar to a dormitory setting, even though inmates are housed in cells in those cell blocks. The virus spread very rapidly in those conditions. Second, we had testing turnaround time problems. Now, we did not have this problem at other institutions where we successfully contained the virus, but we had this problem at San Quentin. Our vendor has agreed to put our tests at a higher priority within their testing system, and we are working with the BioHub in San Francisco to perform some of our tests. We have completed the first round of testing of all patients at San Quentin who consented to be tested. Third, many patients at San Quentin refused being tested or even being assessed for symptoms. So, for example, between 200 and 300 patients in East Block are refusing tests and assessments, and that makes it difficult to manage the outbreak. Yesterday, the prison law office offered to assist us in working with their clients on this issue, an offer we, of course, have accepted, and I'm grateful to the prison law office for their help in this regard. Fourth and finally, the physical layout at San Quentin makes it difficult to manage the population during an outbreak. It has been difficult to separate patients appropriately, and the institution needs additional bed space. We had hoped last week that one way of increasing the available space was to move 100 inmates from the San Quentin Gymnasium to an empty wing of housing at North Current State Prison. To ensure the safety of that transport, we had adopted a much stricter transport testing policy so that all 100 patients had to receive a negative COVID test no more than 48 hours prior to the transport. On Saturday, we learned that 2 of those patients had received positive test results, and we canceled the entire move. As of this morning, San Quentin reports 1,127 active cases, with 809 of those occurring in the last 14 days. We have had 1 death of a patient who tested positive for COVID-19. We've had 42 hospital admissions out of San Quentin. I believe during the week of July 6th, it is likely that we should be seeing a significant number of the positive cases at San Quentin, perhaps as many as 300, move from active to resolved status, since we know that we have at least that many positives who are still asymptomatic. Our 2 biggest concerns now are insufficient resources at San Quentin to handle the enormity of the crisis and the capacity of local hospitals to deal with the flow of San Quentin patients. The administration is responding to the resources problem by directing Cal OES to establish a unified incident command to help manage the outbreak that began yesterday, I believe. And we are redirecting an associate director from the Division of Adult Institutions and a regional healthcare executive to support institution staff and the incident commander. This will help stabilize response to the outbreak. The state has also flown in tents for additional clinic and housing space, and Cal OES will be bringing in a field hospital to provide more beds and housing. With respect to local hospital capacity, we are in frequent ongoing contact with Bay Area hospitals. And at this point, we are confident the necessary capacity exists. For example, Seton Medical Center in Daly City is making itself ready to accept a substantial number of our patients, and we have other arrangements in place with other hospitals. We do monitor this on a daily basis because we know that hospital utilization can change rapidly during the pandemic. We also appreciate that Marin General Hospital, San Quentin's primary local hospital, does not itself have sufficient resources for our likely needs. And they and the community are understandably concerned about their ability, even in their emergency department, to stabilize patients before transfer to other hospitals. We'll continue working with Marin General, and if it appears that Marin General cannot handle the flow, arrangements will be made to transport patients directly to other hospitals so as not to overwhelm Marin General's resources. We are sensitive to their concerns. Let me close with a brief status report. System-wide, we have 2,600 active cases, 2,200 cases that have resolved, and 22 deaths. That gives us an overall death rate of 0.44%. While acknowledging the statistical challenges of different population sizes and confounders, CDCR's crude death rate of 0.44% is a magnitude of order less than the state of California's COVID death rate which is 2.7%, and the United States' overall COVID death rate, which is 4.9%. Don't put too much reliance on that comparison until we've had an opportunity for the California Department of Public Health to perform a more granular, better analysis of the comparison to make sure that we're not comparing apples to oranges. We have had very large outbreaks in 4 prisons: San Quentin with 1,113 positives, Chuckawalla with 1,012 positives, Avenal 938 positives, and CIM 896 positives. The outbreaks at Chuckawalla and Avenal have mostly resolved. CIM and San Quentin, CIM has not resolved, San Quentin we're at the beginning of. Next, we successfully managed a moderate outbreak at California Institution for Women, which had at one time 168 total cases, but which now has only 6 cases. And only one of those was in the last 14 days. CIW experienced 1 death. A second prison, Lancaster, also had a moderate outbreak with 128 positives, all of whom have now resolved with 0 cases in the last 14 days. We have another 4 prisons with moderate outbreaks that so far appear to have peaked with around 200 or fewer total cases. Finally, we have 14 institutions that have experienced small outbreaks that have not blossomed into moderate or large events, and 11 facilities with no COVID cases among inmates currently identified. These are significant achievements given COVID's ease of entering and spreading in congregate housing settings. These numbers, I think, do indicate that COVID has not spread yet throughout the CDCR system in an uncontrolled fashion. But given that COVID is going to be with us for quite some time, I share everyone's concern that what we have done to date still is not enough. There is more that can be done because the virus has plenty of time to continue spreading throughout the system. Right now, and until things stabilize further system-wide, Secretary Diaz has closed intake again, stopped all unnecessary movement between institutions, reimposed a system-wide modified program, and adopted a new and continuing accelerated release program. And I know that he shares my view that we will not open intake or start movement again until we have assured ourselves and others are assured that it can be done safely. Thank you, members, for your attention. I'll be happy to take questions along with the rest of the panel.
Thank you, Mr. Kelso. So members, we've now heard from the panelists for the first panel, so I will open it to questions. I would first, though, like to ask, and this can be Secretary Diaz or Mr. Kelso, while there was indication that there's now limited numbers, I just want to be clear that by CDCR's own statistics posted on your website, there have been incarcerated individuals who have tested positive at 24 out of the 35 facilities. That's by on your own website. Now, I would suspect there could be far more than that, only because it is my understanding, and it seems to have been confirmed by all the panelists thus far, that not every inmate is tested. So since there's not thorough testing, we can't know. But additionally, there is staff who have tested positive at 34 out of 35 facilities. The only facility where a staff has not tested positive, and this is on CDCR's website, is the Sierra Conservation Center. However, one incarcerated person did test positive for the virus, so that shows that the virus has been present or is present at all 35 facilities. And while there may not be active cases at all facilities, since we also do not require the testing of the staff, and additionally, staff report on whether they have COVID is self-reported, I guess the point of this is, when are we going to require staff to be tested? And when are we going to require staff to have to inform the department when they are positive? And similarly, when are we going to have more thorough testing of the incarcerated population? And either Secretary Diaz or Mr. Kelso, you could respond.
So Clark, I'll take the staff testing piece. So as far as the staff testing goes, we are aggressively trying to seek greater contracts to provide greater testing at all of our institutions. But as said earlier in my statement, it is difficult to receive and obtain contracts to be able to sufficiently test all staff members at all institutions. And with that, because of that concern, I have leaned into with the California Office of Emergency Services with Director Garladucci, just to see if I can get resources and assistance from the California National Guard. But in the meantime, we have began seeking to test at institutions where we have outbreaks. Staff are required to let us know if they have tested positive in the community. They do let us know. The majority of the staff positives are reported to us because they have tested in the community or at their own doctors. They reported back. So that is in place now, and that is a requirement by staff that they must let us know that they've tested positive.
Madam Chair, on the side of inmate testing,
Yes.
Through March and April, we simply, as Dr. Galley has indicated, we didn't have testing resources to conduct the sort of testing that widespread testing that would let us do surveillance of how many institutions had COVID. Now, we did finally, as testing resources became more generally available in May, institute a surveillance testing program where we did not test all inmates because we still didn't have that much testing capacity. But we, based on a statistical model prepared by our public health division, tested statistically significant samples of inmates at all institutions to see if we could identify where we had COVID present in the inmate population. And if we found a positive case, then we would focus attention on we need to test everybody at that institution. Today we have essentially 20,000 or so to 30,000 or so tests available to us that we can use on a weekly basis or so. It is currently being examined how we can expand the surveillance testing program, because we don't think our sample size was large enough so that we could catch enough prisons early enough to prevent larger outbreaks. So we're in the process of now doing the same thing Secretary Diaz is doing on the employee side, trying to figure out how can we expand the number of inmates who get tested. We do have the challenge, even with an expansion of that program, of a significant number of inmates refusing. And if we start suddenly saying we're going to test every inmate every 7 days, I'm quite confident that we will have a very large number of people refusing to undergo testing at that rate. And that certainly complicates any efforts to identify where you have COVID. It's not an insurmountable problem, but it's something that you then have to consider as you evaluate the results you're getting from your testing program.
I'm going to turn to Senator Mitchell now. I have many more questions, but I will allow Senator Mitchell. Go ahead.
I appreciate that, Madam Chair. I'm going to have two to Receiver Diaz and one to, two to Receiver Kelso and one to Secretary Diaz. I'll start with Mr. Kelso. I was struck by your statement at the beginning of your testimony when you really, based on the ruling of the court, equated your position on par, quite frankly, with Secretary Diaz in terms of your responsibility with regard to health care delivery system in the prisons. And I appreciate your accounting by date, starting mid-June of when you intervened and took action with regard to San Quentin. But I'm curious, from your perspective, what responsibility do you take with our current level of outbreak system-wide?
Thank you, Senator Mitchell. My responsibility from the court order, when I said I had Secretary Diaz's powers, that is exactly what the court order says. So I have his operational responsibilities with respect to CDCR's medical care system. And therefore, I share all of the same accountabilities as the Secretary of the department. So I've been involved from day one, along with Secretary Diaz and his Undersecretary for Healthcare, Diana Tosh, on all COVID matters. And I'm accountable and responsible both for the successes and for the failures.
Thank you for that. I appreciate that. Secretary Diaz talked about the lack of infrastructure with regard to testing. And so I'm wondering, what is your internal capacity? He talked about needing to find a vendor who could manage testing. And so I'm wondering, what is your internal capacity, given your role and given the fact that health personnel still on large part report to you? What's your internal capacity to ramp up testing for perhaps both those incarcerated as well as personnel operating within the department?
Senator Mitchell, my responsibilities are to the care of inmates. The question of staff testing, including the testing of medical staff and healthcare staff, is really the responsibility of CDCR's Occupational Health Office, their wellness office. Now, I have testing capacity that we are using for inmates, and but I'm reluctant to divert any of that for staff testing.
Fair enough.
I know that Secretary Diaz and his team, they are and have been in the process of establishing contracts for staff testing, but I need to let Secretary Diaz, I think, take that part of the question.
Well, fair enough. Let me reframe the question, because my real question is, in what I heard from Secretary Diaz, I got the impression that he's looking for an external contractor to be able to have the capacity to test inmates. So let's leave, fair enough, you're absolutely right, let's leave personnel aside. What is your internal capacity to provide the kind of testing that we all now, well, many of us have always believed was necessary, but now everyone seems to be on the same page in terms of consistent, regular testing, even repeated testing of inmates? Do you have the internal capacity to provide that testing of inmates system-wide?
Thank you, Senator. I appreciate the clarification. We believe that right now we have the capacity to do the ordinary surveillance testing that, even with an expanded program, that we need to do. Our own nursing staff is able to conduct that type of testing program. We have our test kits provided by our outside general vendor who does all of our laboratory testing. And we are able to send all of our samples to them. When they get test results, they are immediately transferred electronically into our electronic health record system, so we get results back immediately. I think that when we have outbreaks during that critical 2 to 3 week period, when you need to suddenly be testing thousands of inmates at once, for there we are more challenged. There are two things that we do. First, we have to divert all resources to testing and away from most general health care. So general health care functions tend to suffer during that period. The other thing that we've done that I think was helpful to us in some of the outbreaks in Southern California, we had good support from local public health offices who helped conduct some of that surge testing. And that helped. We still have the problem at San Quentin, even right now, where in order for, even after we've done all the testing, in order for nurses to actually do twice daily assessments of patients who have tested positive, we don't think we have sufficient staff for that. It's a workload that's much higher than we are staffed for. And we are at San Quentin looking at bumping up their staff resources, both by diverting nurses from other institutions and by increasing our reliance upon registry nurses. So during that surge period, we are challenged.
And is there a plan for that? Now that we've identified that you have a challenge, is there a proposed solution?
For San Quentin, there is a proposed solution. It's to immediately send them nurses from other institutions with registry. That's not a long-term solution because if we get too many prisons simultaneously having large outbreaks, we won't be able to support it. So staff is at this point, I don't have a solution for it yet, but they are at this point exploring how do we get surge staffing when we need it. My understanding is, and I think we're seeing this in the Bay Area, there are a lot of people, a lot of nurses who are interested in helping out and providing services. I think the governor's office earlier had announced a program for healthcare professionals to donate their time, make themselves available. So we're going to be exploring all options because we're concerned about the capacity of our nurses over the next 12 to 18 months, if that's how long this all lasts. We're going to need to have more capacity.
Thank you. And I, Mr. Kelso, appreciate your definitive, clear statement around responsibility. I appreciate that very much. To Secretary Diaz, you know, I am chairwoman of the Joint Legislative Budget Committee, and the JLBC, through provisions of Section 36, Chapter 2 of Statutes of 2020, we are the entity that approves, if you will, or concurs with non-budget action items as requested by the Department of Finance. And so, if you allow me, Madam Chair, just very briefly, to, for the record, for the purposes of this committee, you know, acknowledge the multiple Section 36 request letters we have received from the Department of Finance on behalf of the Department of Corrections with regard to reimbursing counties for housing inmates due to the temporary stoppage of prison intake in response to COVID. And we have concurred with all of those requests. The first letter came April 2nd. We responded April 5th. We concurred, always with statements of concern about the severity of COVID-19 crisis, and requesting that the administration provide a detailed plan for mitigating the spread of COVID-19 in the state's correctional populations. That request was made April 5th. The next letter came from Finance May 8th, asking for an additional augmentation because they were now again halting intake from counties. And again, the augmentation request is to reimburse counties now for holding inmates that should have been, you know, processed and gone through intake and corrections. And because we were asking counties to hold them now for another 30-day period, it was an additional $8 million request. Once again, JLBC concurred with the necessity of those changes. Again, no response in terms of their full plan. And May 11th, we responded to the May 8th request. Once again, respectfully requesting that the JLBC be provided with the public health guidelines that are being used to establish the physical distancing standards, the modeling and the data that shows the current prison population level and the proper physical distancing population level were being done. Again, with every request, we concurred and asked for documentation so the legislature could be confident about what was happening in our prison systems. June 17th, another Section 36 letter we received from Finance asking for an additional $16 billion, to which we responded in a rather lengthy letter June 20th, where once again we asked about the plan. However, in the staff briefing with Department of Finance staff, with JLBC staff and Senate budget staff and Assembly budget staff, we were told in the state briefing that they intended to begin processing intake of up to 700 inmates per week. Again, this letter from Finance was dated June 17th, and the briefing probably occurred within a day or two. We replied June 20th with probably one of the most sternly framed letters I have penned as JLBC chair, that said the department needs to demonstrate that it has policies and procedures in place that protect the health and safety of staff and inmates, and its data needs to show that policies and procedures are working. Given the problems that the department encountered after admitting inmates from LA County, I urge the department to develop strict protocols with each county to ensure that individuals transferred from county jails to state prisons are negative of COVID-19 before they are transferred to a state institution. And I end the letter saying that we request that the administration halt intake from counties until the department can ensure that only inmates who have tested negative, again, been tested, be transferred to the state institutions. We then received an email June 24th confirming that no additional inmates would be transferred. So thank you for the time, Madam Chair. I just wanted to walk through, in the context of JLBC in this one area, our constant, consistent efforts to communicate with the Department of Finance on behalf of the legislature, our concern about their practices. And so with that, I'd like for, unfortunately there's no one from Finance on the panel, but I'd like to hear from the Secretary in terms of what level of confidence would he suggest we have as city members of the legislature that based on their lack of response for the last, since April 2nd, that on a go-forward basis that there's a level of confidence that they are going to be communicative with the legislature in terms of what their plan is going forward to attempt to curb the ongoing spread of COVID-19.
So thank you for the question, Senator Mitchell. And I will say, in regards to county intake, I believe and still believe that the closing of the county intake was essential in curbing the spread of COVID. Then there's also the challenge and trying to work as a partner with our county entities and the sheriffs, recognizing that they also have pressures. So the initial call to close for county intake wasn't an easy one, but then it was also not easy to tell them we're going to continue not to take inmates from the county jails. There was a plan to take only 200 inmates in, 100 for Wasco and 100 for North Kern. The 700 intake number, if that was, I think that may be an error. We never intended to bring in 700 to our system and our reception centers because we reduced the number of our reception centers to 2, to Wasco and North Kern. Prior to that decision, we had up to 5 reception centers. We had one in Chino. We had one at San Quentin. We had one at DBI. We have one in Delano. We have one at Wasco. And then for the females, we have one at the California Correctional Women's Facility in Stockton. So narrowing it down to only 2 ports of entry at North Kern and closing the county intake was a good strategy, and I continue to believe that's a good strategy. As far as the reports that that finance owes, or in turn we own finance, I will say on our end, I'll admit there's been an over-reliance on our posting of our plans and directives on the internet and directing many people to the internet in regards to everything from our inmate cohorting to our testing of staff to our testing of inmates to the closures of programs, the movement between institutions, and the program status of every institution. I believe there's been an over-reliance on our end, and we do need to develop a more comprehensive and cohesive document rather than refer everyone to the internet. And I have a binder here with many directives in it, and I'll be the first to admit we need to gather those and put them into one document as overall report. But as with any reports, especially during COVID, it is going to be ever evolving, ever moving. And but as far as the funds that are being distributed by your committee, Senator, I do appreciate it. Corrections is better for it. But I hope you do trust that the decision to not take county jail inmates isn't taken lightly on our part. There's been a lot of communication with our sheriff partners. They're a partner in this with us. The plan, there was a guideline sent to the sheriffs early to mid last week, giving them clear direction on what types of inmates are to come to us, what is their testing protocols, and they have been good partners in it, and that criteria has been worked in collaboration with the receiver's office to make sure the receiver's office is in agreement that the questions that we're asking and what we're requiring of the counties is consistent with our COVID mitigation strategies. But even with the spikes that we've seen in the last 2 weeks, I sent a letter to the counties informing them that regretfully telling them we have to continue to close the intake for another 30 days. What that does allow us to do is, number one, take a look at the vacant capacities in our reception centers, which now exist because inmates are not coming in, and to strategize with the receiver's office to depopulate other locations where we may have crisis areas that we cannot depopulate or reduce the density at institutions, and move individuals as cohorts after being tested and quarantined at the sending end and on the receiving end. So I hear you loud and clear, Senator, about the overall plan that we owe finance and that finance owes you. But again, I will chalk it and I will say that it's been an over-reliance on our internet and posting all of the various plans that I've cited on that website.
So just say in response, and I'll end now, Madam Chairwoman, you know, many members are often concerned about unfunded mandates, actions we take at the legislature that have financial impact on local governments. And let me be clear that we have paid for stopping the intake from the county level. So they have received reimbursement. And Mr. Secretary, I'm not sure of the source of the mistake. Let me just state that in the staff briefing with finance, we were told 700 per week. And when staff returned the call to clarify that they didn't mean 700 a month, Department of Finance reiterated a second time the intent was to transfer, let me use your terminology, intake was to pick back up at 700 per week. So if finance isn't coordinating with the agency, problem. And so I appreciate your participation today, and I hope that you are clear that this chairwoman and this committee, as well as I as JLBC, will continue to be directly involved in these ongoing conversations, because we are now at a point of crisis, and crisis management must step in. It is system-wide. It clearly will have financial ramifications on the state as a whole. And the quicker you have a plan where you can ramp up, where Mr. Kelso has the resources and personnel he needs to conduct testing, the better off we will all be, including people who are incarcerated in your department.
Thank you, Senator.
Thank you, Senator Mitchell, Secretary Diaz, for responding. But let me just add to Senator Mitchell's, as in her role of chair of JLBC. I, of course, as a member of JLBC, got to receive each of those letters that were sent. And I just want to reemphasize the point that I don't think was answered, that as far as I know, because I would have received a response, that none of the requests that Senator Mitchell, that the JLBC sent, each time the JLBC authorized the expenditures, that the requests for information were never responded to. So while there may have been things on a CDCR website, there was never a formal communication that we should look at the CDCR website to answer our questions. Now, certainly there have been some of us who have been monitoring the CDCR website all this time. For example, I wouldn't have been able to cite the data I just cited before around the staff at what facilities and the incarcerated individuals at what facilities. All of that is right there on the CDCR website. But I think, and I really appreciate Senator Mitchell's pointing out that JLBC has been requesting this information and pointing out the necessity for a plan for months. And I'll leave it at that. Senator Wiener, I want to ask one question before I call on you, so apologies. Mr. Kelso, and Secretary Diaz, you can respond also. But Mr. Kelso, you mentioned that, and I appreciate Senator Mitchell's having you clarify the authority of your role. But you mentioned that guidance was given starting at March 20th and on, various guidance. And my understanding that while it's not been said yet by Secretary Diaz, in the calls that I've had with the department over the last X number of months, there was a certain point where I was informed that system-wide, there was the requirement for staff to wear masks. What I want to know is whether in fact there was that requirement, whether the receiver was involved in making sure that that requirement was either issued and enforced, and from CDCR, was that requirement enforced, that all staff wear masks? Because anecdotally, what we hear is that staff do not wear masks, some, but it's irregular. And so I would like to have the answer to that question.
Thank you, Madam Chair. I'll give an answer I suspect Secretary Diaz will want to amplify. Both Secretary Diaz and I have issued directives that staff shall wear masks. We've done it twice. I also, because we heard similar sorts of concerns that, well, how do we know people are wearing masks? And there's also a requirement that inmates wear masks and observe social distancing. I sent out from my office a team who reviewed 15 or 16 different institutions, the ones that we thought were the most critical for review, with the sole purpose of getting a report back on how well are both inmates and staff doing in complying with those directives for social distancing, masks, and so on. And I did receive a report back last week, some 160 pages worth of detail about the degree of compliance. It is not uniform. In general, it appeared that there was only one prison where the report described the prison as not taking seriously enough COVID. That prison was CIM, surprisingly. I don't see how they could not be taking it seriously given the extent of the outbreak there. For all of the other prisons, the report came back that it was being taken seriously. We've had great cooperation with the inmate advisory councils and inmates in general in their observance and most institutions. We have some inmates who aren't going to comply and don't comply with much of anything. But by and large, I think we're doing pretty well. We have indicated in our Secretary Diaz and I, in our most recent memo, that it is the responsibility of institution leadership to enforce the requirement using the progressive discipline system. So I do believe that it is by and large being enforced and observed. Judge Tigar, my judge in my case, he visited Solano earlier this week, and the report I received back from Judge Tigar was it looked to him like people were in general complying with those sort of requirements. Secretary Diaz?
So to amplify what Mr. Kelso said, it is a requirement.
When was the requirement issued?
I could give you the dates. It had to have been around late March, mid to late March, but then we just signed another memorandum less than 2 weeks ago amplifying and reiterating the need to wear masks. I also did
The need or the requirement?
The requirement. So it is required that staff wear masks. And like Mr. Kelso sent a team out, I also went into prisons myself. During, it was last month, I drove to Southern California, didn't hop a plane by myself, drove just to, number one, check on the status of the institutions, but two, to also look at myself for the compliance of mask wear. And of the 7 institutions that I toured, staff were in compliance. And I know there's times when staff know the secretary's there, so of course there's going to be heightened awareness. I'm well aware of that. So that's why I made it real clear in my observations, not just to look at what was in front of me, but what was behind me and yards next to me, to talk to inmates, to talk to staff, and compliance is mandatory. We have communicated this with the bargaining units. The bargaining units are on board. The bargaining units have been very supportive of this. They know it benefits their membership, and they recognize that if progressive discipline has to be taken on employees who fail to comply or don't comply, that there's an understanding that it's a requirement not only by the Department of Corrections, by the receiver's office, but it's just the right thing to do as a state.
Thank you. Senator Wiener. And,
thank you, Madam Chair. I have some questions for Secretary Diaz about, as I mentioned at the beginning, transfer of people from CDCR to ICE detention facilities. But one quick question before that. I've gotten some feedback that staff or medical staff at San Quentin may not have the PPE that they need. Can you just comment on the level of access to critical PPE at San Quentin?
I can give you, I get an update on a daily basis from our logistics office and our department operations center. KN95 masks, currently we have 1,264,000, surgical masks over 5 million, N95 masks 232,000, over 500,000 gowns, over 300,000 face shields, and we have over 10 million pairs of gloves. So since the beginning of COVID, CDCR, the Department's Operations Center, the Receiver's Office, we've spent nearly $30.3 million on PPE for employees. I will say in the beginning, when COVID first hit, as much of the state, there was some struggling to try and find that supply. But since then, we have ramped up. If there are concerns at San Quentin about PPE, that is reported up through the institutions, through our operations center here, and we address it. I haven't heard that there is a lack, but if there is, we will be addressing it.
Senator Wiener, I just want to say, I have heard that there is a lack of PPE at San Quentin from staff at San Quentin. Go ahead, Senator Wiener.
So if you maybe look into that to confirm, because we're hearing this from reliable sources. So regarding ICE transfers, Secretary Diaz, I want to know, since the beginning of the year, how many people has CDCR transferred to ICE detention facilities, and has the department been tracking whether these individuals are being transferred to ICE detention facilities where we know that COVID is spreading? Because the data that we've gotten is that 1 out of 3 individuals in these detention facilities is COVID positive. So how many have been transferred, and are you tracking whether they're going to facilities that have COVID issues?
So thank you for the question, Senator. So as far as the number, I will have to get that to you from the beginning of the year. I can probably get it by the end of the day. But I will say, when we say the term transfer, we CDCR do not transport any inmate to ICE custody. If an individual has served their term and their term is up, and there is a hold or a warrant by ICE as a pickup, we pick that. They're picked up by ICE just like any other law enforcement agency who may have a hold on an individual to take into their custody for their reasons. But we do not transport inmates ourselves to custody. So if someone leaves our prison system, that means their term is up, it's over. If ICE is there to pick them up and there's a valid hold in place, then they get turned over to ICE and they're taken. If there's a hold and nobody's there to pick them up, we release them. So the thought of we transporting or somehow the CDCR has oversight over that transport, it's out of our purview. If they finish their sentence and they're done and there's a hold, they're taken into that custody, whoever picks them up.
But so I understand that CDCR is not the one doing the physical transport, but my understanding is that CDCR informs ICE, I think 5 days before release, and that's how ICE knows to pick someone up when they're being released. So CDCR, from what I understand, is clearly involved in facilitating whether you want to call it a transfer or a handoff from CDCR to ICE of people who have completed their CDCR sentence or who are being released or paroled, and CDCR facilitates them being picked up from ICE upon their release and then taken to an ICE detention facility. And so does CDCR, first, is CDCR, since COVID has become a real major issue in California, let's say starting in March, has CDCR continued to do that, to facilitate ICE picking up these people who are being released? And does CDCR look into whether they're going to be taken to a facility with a COVID problem? Is that happening?
So pre-COVID and current COVID, if there is a hold in place given by any law enforcement entity, whether it be ICE, whether it be Los Angeles Sheriff, whether it be the state of Georgia, and that hold is in place, and they're there to pick them up, then we release them to their custody. After they're out of our custody, we're not checking where they go. We're not checking the status of the facility where they're going to. They are now in the care and custody of the entity picking them up.
Right. So, but am I correct that CDCR does not have an obligation to alert ICE and to facilitate the handoff to ICE of these detainees? You're not obligated to do that. CDCR is choosing to do that. And given what we know about what's happening in these private prison ICE detention facilities with COVID, why is CDCR continuing to alert ICE that people are being released and to facilitate the handoff? Why are you still doing that? And will you stop? I think CDCR needs to stop doing that.
Okay. So as with all holds, there is contact made with the entity that initially placed the hold to inquire, are you going to pick this individual up or not? That is a question that we would ask, not just ICE, we would ask any law enforcement entity, are you going to pick them up? If they say we're not, then we lift holds and they just go home. If they say they are, we'll let the individual know that you have a hold so they can make their arrangements, communication with families. But we handle ICE just like we would any law enforcement entity who is requesting that they're going to pick them up. We don't handle ICE any different as we would any other law enforcement entity. And if there is a hold in place, Senator, we will continue to enforce that.
But I guess the question is why? You don't have to treat ICE like any other law enforcement agency. And frankly, ICE is not like other law enforcement agencies. We know all of the problems with ICE going well beyond COVID in terms of how they treat immigrants in these detention facilities and the problems we've had with people dying, with the way that LGBTQ immigrants are treated, with the way that families are treated and children. And then we have COVID, where once again, they've done a terrible job. And so CDCR is not required to coordinate and facilitate ICE picking these people up. You're choosing voluntarily to do so. And so my question is, why are you choosing to voluntarily do so? And will CDCR commit to stop doing this? This is making the COVID situation worse. It's harming people. Will you stop doing this?
We will continue to follow our policy as it states. If there's a hold in place, we will continue to work with any law enforcement agency, including ICE, if there is a hold in place to turn them over to their custody.
Okay, well, I'll conclude by saying I could not disagree with CDCR's voluntary policy to hand people off to ICE. I could not disagree more. This is making the COVID situation worse. The legislature has been clear with the passage of SB 54 that we do not want to facilitate the Trump deportation machine. And even though, yes, the governor did veto AB 1282 last year by Assemblymember Kalra, it's never too late to correct a mistake. And I hope that this mistake gets quickly rectified and that we stop coordinating with ICE.
Senator Morlock.
Thank you, Madam Chair. Secretary Diaz, it's an honor to serve on the Public Safety Committee, and last year we had at least a good chance to talk about a lot of topics, so I'm sorry we're just so limited today, but I had a question at the beginning, and that was that there was a video showing inmates intentionally spreading COVID-19. So you have a constituency that's a little different than those that are in nursing homes where they are trying their best to avoid any contact, and yet here we have many that are actually intentionally trying to get COVID-19. So you have a unique constituency, and I'm trying to remember what they were trying to do, whether it was to be hospitalized or whether it was to be moved out. But could you help me with that news report? Was it accurate? Was it, and what was actually going on?
I think the report, if we're talking about the same one, it was referencing a Los Angeles County. It was referencing Los Angeles County Jail.
Okay.
And the report was that they were intentionally trying to spread COVID for whatever reasons, possibly trying to seek early release as COVID numbers go on. I really can't speak for LA County. As far as the prison system, I haven't received reports that that is the case. However, nor am I actively asking staff to investigate and find if that is happening. If that is happening, I'm sure that the inmate population itself would self-report that because this crisis isn't just immune to healthy individuals. It would be the high-risk medical that would high-risk patients that would probably inform staff that that is occurring. But I have not heard that's the case. But again, I haven't actively pursued. I don't want it to be counterproductive. We are working closely with the population to communicate. We are working closely with the staff to have open dialogue with our healthcare staff, with the receiver staff, and the CDCR prison staff. And if that's happening, I have not heard it. But if something like that would be occurring, I would be notified immediately.
Great. I thank you for the clarification. That is most helpful. You've been working with Receiver Clark Kelso, and he has been working in tandem. I just want to know, is the receiver still adding value, or is the receiver redundant?
No, I think that the receiver's partnership with CDCR, it is value added. There is expertise that does exist in the receiver's office that CDCR relies heavily on. And the partnership with the receiver, especially Mr. Kelso and myself, has been stronger now than ever. There are resources and knowledge and experience in the receiver's office that CDCR lacks. And I consider him a great partner, so I don't consider it redundant.
Thank you, Secretary Diaz. Receiver Kelso, after that glowing report, I'm just curious, I should ask you at least once a year, are you still necessary? And how long do you see your role lasting?
Well, thank you, Senator, for the question. As you know, my court has directed me for about 7 or 8 years now not to try to put a firm date on ending the receivership. What I can say is you are making steady progress forward in the delegation process, which is the process to end the receivership. Essentially, when COVID struck, I have now not been able to focus in the last 4 to 5 months on what are the next set of institutions that are ready for delegation. And frankly, I think there are a number that are ready for delegation that have not yet been delegated. I'm hoping over the next month or two to figure out how I can reorganize my own attention so that I can get back to the process not only of working with Secretary Diaz on COVID matters, which I think are the highest priority, but so that I can continue the process of delegating back to the state, moving the case along toward its conclusion. So we've been on hold in terms of that progress for 4 or 5 months now, but I hope to get back to it.
Thank you, Receiver Kelso. Thank you, Madam Chair.
Thank you, Senator Morlock. Senator Bradford.
Thank you, Madam Chair. I had a question for Secretary Diaz as it relates to personnel, staffing. It's been brought to my attention. I participated in a call a little over a month ago with one of your facilities, and it was brought to my attention along with the chair of the Assembly Public Safety that some of the facilities are lacking medical directors, or if they do have a medical director, they're in an acting capacity beyond their skill set. Is that still the case?
Thank you for the question. If medical director, meaning the chief executive officer over healthcare, that's more in line of a question for Mr. Kelso.
Oh, at each facility?
At each facility. Each facility has a chief executive officer who is over healthcare. They are equivalent to our wardens at the institution.
Okay.
As it relates to healthcare matters.
All right, then. To Mr. Kelso, then. Thank you.
Yes, thank you, Senator. We do have a small number of acting CEOs. Most of our CEOs have been with us now for many years, frankly, and they are a very experienced group of healthcare, usually former hospital administrators who understand very well how to manage a staff of health professionals. To the extent we have acting, it's because people retire. They decide they've had enough. And we are constantly in a process of recruiting for CEOs and for chief medical executives. Because we have vacancies, we need to have a pool of people to choose from. And if you have a particular institution that you're concerned about, please do feel free to contact me, and I can respond more precisely. But by and large, our CEOs, all of our positions, the vast majority of our positions are filled with permanent, experienced leadership.
Because, again, the call that I received along with the chair of the Assembly Public Safety, that they had people in acting capacity, but not necessarily in their skill set. Now, they might have broad understanding, but it wasn't specifically as it related to healthcare and addressing this COVID issue that we're facing right now. So, thank you.
Thank you, Senator Bradford. I want to move on to our next panel. We have a hard stop at 1 o'clock today, and we obviously want to hear from the public also. But before we do, I want to two things. One, I appreciate the honesty, Mr. Kelso, in describing the issue of the transfer, how your matrix, as I understand it, what I heard was that there was the requirement of testing, however, he never specified when. But I guess what I would have to say about that is if there is a chief medical officer at each facility, and anyone who understands the way this virus spread, and maybe in March we didn't fully understand, and maybe we didn't have adequate testing. But by the end of May, we fully understood and we had adequate testing. So how there could have been the transfer with people that had not been tested for 2 to 3 weeks, it's abhorrent, and I still don't understand it. I don't know really if there's a comment to make or not. I just have to make that statement. But I guess the question I have is, and this is to both Mr. Kelso and Secretary Diaz, but perhaps Mr. Kelso primarily, as the person who is in charge of the delivery of health care, and since your guidance indicated there's the need for social distancing, physical distancing, and you've acknowledged that that's difficult in these settings, and we all know that we are overcrowded, do you have the authority to require releases? And those releases do not necessarily have to be back to community setting. They could be into other facilities, for example, and I don't mean just prison facilities, but I mean facilities where people could be not crowded, could follow the appropriate guidelines. Do you have that authority? And before you answer, I just want to, since this has been talked about, I just want to make it clear to any public that's listening, the numbers that have been referred to of releases so far have all been releases that would have happened on the natural. On the natural, 3,000 approximately people are released from our prison systems every month. So that the fact that since late March we've released some 7,000 is not highly unusual at all. So I guess I wanted to, in terms of this plan for how to deal with this spread, whether there is any plan for releases to accommodate, to be able to achieve the appropriate physical distancing and the other guidelines. For example, if we have people in dormitory facilities or we have people in cells that don't have solid doors.
Madam Chair, thank you for the question. The issue of releases and who to release have been before the court in the case. The court's been holding hearings about every 7 days for a while, and now most recently about every 10 days. And the question of releases is before the court. I do not believe I have authority myself to order housing changes or releases that would put patients outside of the institution, except for ordering patients to go to higher levels of care at hospitals. So I don't believe I have the power to do what you're asking.
Senator Mitchell.
Thank you. It was in listening to your question, I'm reminded of the numerous stakeholders and academics who are at least sending me in my office their creative ideas. You know, people asking, is there an emergency plan? Creative ideas about partnering with other agencies in terms of transfers. And so I'd like to know if the Secretary, Mr. Kelso, are getting them, if there is a repository where people can be sending these creative ideas to them. I appreciate them coming to my office because of today's hearing, but to get them into the hands of the two gentlemen who are the decision makers and who have, albeit limited, power to make some of those decisions. How would they like to receive that input from informed people, stakeholders, academics, and others? Where should they send them?
Senator Mitchell, I'd welcome some of those recommendations or some of those ideas. We have been looking at various options, but you know, with the various options, we also need to keep in mind we need to put them in locations so where we are not going to make a bad situation worse, like a homeless situation. That's what we don't want to be doing. It is, I think I will concede that our ability to provide adequate reentry services after incarceration needs to improve. We have good partnerships with reentry services in our communities. The expansions of that is not cheap, and but in a way that if there's any other creative solutions like the usage of empty college dormitories, of you know, empty jails, but I also, before I would do that, I would be looking at the empty housing units that do exist within CDCR and maximize those to reduce density at institutions. If I can house inmates in empty buildings, let's just say on a single cell basis, that would create density. And I do have empty buildings in the system, but however, due to the COVID issues that are existing, we have really minimized those transfers. So I'll stop there.
I would just say, Mr. Secretary, given your workload, I don't think it's realistic to expect that we shift all of the correspondence to you. So if you could identify someone on your team at an executive level who could receive and be in communication with these stakeholders. Again, the recommendations we've seen are, again, also inmate focused and would not suggest homelessness, would not suggest into a setting that would not provide the appropriate support and resources. So if you can identify someone we could direct it to, I think that would be helpful. I think that'd be helpful.
Yeah, I think now that I think about it, it should probably be my legislative affairs chief, Sandy Uribe. You can send those to Sandy. She can collect them.
Thank you.
Thank you. And it is July 1st, so the money that we approved in the budget is available, and there was a carry-on of additional funding that the BSCC is administering that can support community-based groups that provide reentry beds. So I think that that is something that needs to be incorporated in whatever plan is being developed by OES, CDCR, and Department of Public Health. That we have already allocated funding, has not been distributed yet, but there may be, for example, there's many reentry organizations, Amity comes to mind, there's many others that do provide reentry beds and who may have spaces, and that should be thoroughly explored, and the funding that was appropriated by the legislature needs to be looked at for that purpose. And with that, I want to turn now to the second panel, and I appreciate Secretary Diaz, your answering our questions and participating. Also, Mr. Kelso, and previously our Department of Public Health representatives, Dr. Ghali and Ms. Finelli. I appreciate your participation, and I want to move on now to the second panel, which is folks who can talk to us about the impact of COVID-19 on the prison community, both inside and outside the facilities. And we're going to have Sam Lewis, who's Executive Director of the Anti-Recidivism Coalition, followed by James King, who is a staff to the Ella Baker Center and was both Mr. Lewis and Mr. King formerly incarcerated. We have Glenn Staley, who's the president of our California Correctional Peace Officers Association, and Dr. David Sears, who's Associate Professor of Medicine at UCSF, and who's part of AMEND at UCSF, and who is part of the set of doctors that Mr. Kelso referred to as he asked the set of UCSF doctors to go to San Quentin and look into the situation. So that's who we're going to hear from now. And apologies to my panelists that we're starting at 11:30, but that's what we are. And we have to hard stop at 1, and we know there's lots of public who want to add. So we want your information. If you can keep to your time, greatly appreciate it. So let's start with Sam Lewis. If you're on mute, you'll have to unmute it.
Yes, ma'am.
Okay, you're right. We got it.
Good morning, Madam Chair. Thank you, and thank you, esteemed Public Safety Committee, for allowing me to share both the advocacy work that ARC and many other organizations have been involved with, along with much of what we've been hearing from families and people that are currently incarcerated. So just to give you a quick number of dates, on March 13th, March 16th, April 16th, and June 5th, ARC, Uncommon Law, and probably about 40 other advocacy groups began and have been consistently advocating to have people released early for specific demographics. We've been sending our requests directly to the governor. And so we've really taken time to be thoughtful about what this would look like. And so we advocated for the release of people that were 60 and over, especially those that had underlying health conditions. We also consistently advocated for people that may have been released within the next 6 to 12 months. We asked for expedited release of people. We believe it was between 600 and 800 people that were currently still incarcerated but had been found suitable by the Board of Parole hearings to expedite those releases instead of having those people stay inside and wait for 5 months for clearance. We've also advocated for Assembly Minority Leader Maria Waldron's Correctional Facilities Emergency Response Act to be considered. And all of these things, we looked at it from the standpoint of both people who have been incarcerated and how to be thoughtful about how this might impact public safety, and at the same time protect both staff and people that are currently in custody. As we had these conversations, we believe that if the governor is serious about saving lives, then these ideas should be seriously considered. And today is the start of the community supervision program, which will be releasing people that fall into a certain category that would normally be released in the next 6 months. One of the things that has truly troubled me as I hear from, especially in the last few days, and it's been heartbreaking and stressful for me as a person that's formerly incarcerated. So just to share a little, 10 years ago, I was in Soledad Correctional Training Facility, and the norovirus was raging through that facility. And I remember doing everything I could possibly do not to get it. I did not come out my cell. I disinfected the cell. I literally did everything I could possibly think of, and I still ended up catching this virus. And it was brutal. It was painful. And I remember being up at 2 o'clock in the morning, diarrhea, vomiting, just miserable, and banging on the cell door and asking the officer, could he get me to medical? And the officer says, we can't do anything right now, because so many staff have been knocked down by this virus. And I remember laying in my bunk and thinking to myself, am I going to die here like an animal that no one cares for? Not being able to write, we were on lockdown, we couldn't communicate with our families. So when people's family call me and they're worried about their loved ones catching this virus and dying from this virus, and they're hearing about what's going on in Chino, and then when I get phone calls and letters from people that are inside, and we pushed a lot of these letters from people inside, speaking to their fear of catching this virus and dying. They don't want to die inside. What are we doing? What can the governor help us? And these are questions that we have no answers to, because we're not in a position of power, but we can advocate and strongly advocate for those voices. One of the things that bothered me immensely was 16 people died in CIM, and there seemingly, to me, was not enough outrage and uproar of those deaths, to me. And I blame nobody, I'm not pointing fingers, but it seemed like if we had jumped on it then and really took action then, maybe it would never reach San Quentin. Maybe. I don't know. What I do know is that, and sadly, but I have to speak this truth because it's been asked of me by many people in the last couple of days. Why did it take for an institution that's located where there's a great deal of power, influence, and wealth and privilege for this uproar to come when people had died already? And it breaks my heart to be able to have to tell them that I don't know, I don't have those answers. In addition to our advocacy work, when we first heard that there were not enough masks inside the facilities, our sponsors, other organizations, we started donating masks. We've donated over 10,000 masks until we knew that CDCR had caught up with all the mask demand. Understanding that inside you're issued 1 bar of soap every week, and one of the things that the health officials tell you to do is to constantly wash your hands. And knowing that you only issue 1 bar of soap, we've donated over 50,000 bars, and we focused on those institutions that had the outbreaks first, starting with CIM, CIW, and Lancaster. One of the things that I'm seeing now, or that we saw in April, was when 3,500 people were released, there was no support for community-based organizations. We did it on our own budgets to provide transportations from institutions to transitional facilities or homes. Many of these organizations are on shoestring budgets, but they still did it on their own dime. And here we are again, and we're about to release another 3,500 people, and it starts today. And again, there's no support for these community-based organizations. We're literally trying to figure out how to cover the entire state of California and provide transportation for people so that they're not on public transportation, and make sure that they have PPEs when they step out of institutions if they don't have them, so that we'll have them and we're able to give them to them. The last thing I'll say is this. We've been asking for specific demographics, the 16 people. So first of all, I've heard it, the separation of there were 22 people in custody that died and 2 correctional officers. There were 24 human beings that died from this. I don't differentiate the two. The correctional officers are there to do a job and they're human beings, and they have families and loved ones. The people that are in custody have broken the law and are now being held accountable, but they too are human beings that have families and loved ones. What are the demographics of these individuals that have passed away from COVID? Would they have been protected or saved if they were over 60 or had underlying health issues? Would they have been protected and saved if we had given them release? If we take a moment just to look at, if possible, maybe reach out to the minority leader and look at the Correctional Facilities Emergency Response Act. It's not just for COVID, it's for anything like this. And I go back to when the norovirus was ravaging Soledad Correctional Facility, it was like, you just have to wait for it to take its course. That's literally what it was like. I've heard from people inside that in some instances, there's robust cleaning inside the facilities multiple times. There's social distancing, only one building can go to a yard at a time. And that there's literally a joint effort with both staff and people in custody. And I've heard the exact opposite of some facilities too. But there's no cleaning and some people are not taking it serious, and that includes staff. And so I have a mixed batch of these reports from people that I know and I trust that they're being honest with me. The thing that I would hope that we would look at is Lancaster, which was one of the first institutions that had an outbreak. They have 0 active cases right now. What did Lancaster do right? They had 2 facilities, A facility and D facility had the cases on them. What did they do right in order to, one, make sure no one died, which may be impossible for us to do, but more importantly, what did they do in order to stop the spread inside their facilities? And if we're not looking at those things, then maybe we should be looking at those things. I'm also here to just say whatever we can do, and I believe I speak for most, if not all, community-based organizations that want to help. Whatever we can do, whether it's providing transportation to and from institutions upon release, whether it's to encourage people that are currently incarcerated to wear masks, we are here to be of service and to help the people that are currently incarcerated, as well as the staff that are in these facilities. Thank you for your time.
Thank you, Mr. Lewis. I appreciate it, and I think that suggestion to look at Lancaster is a very, very good one. And I also take notice that I think there is a correct perception that, and it's not a wrong thing for people to react to San Quentin, and certainly the number of cases. But yes, the fact of where San Quentin is located does give it more attention than some of our other facilities. But I think you know that there have been many, many people in the legislature and outside of the legislature, as you described, who have been trying to get answers and on this now for months. And we did not wait until the San Quentin situation. But at least we have the hope, no, I shouldn't say the hope, at least there's an opportunity now to try, like Lancaster, to get fully control of it. Let's turn to James King from the Ella Baker Center.
Good morning. Thanks to the chair and members of the committee for allowing me to speak with you today. My name is James King. I was released from San Quentin 6 months ago after living there for 6.5 years. During my time there, quarantines were routine. No matter how often I washed my hands, was careful about what I touched, who I was proximate to, I never went 1 year without catching the cold. It's because I lived in a building which was designed for approximately 400 people, but housed nearly 800. We shared 18 shower heads and 12 payphones. The building was poorly ventilated. We lived in close quarters. The windows are welded shut. The cells have bars instead of doors. These cells are 4 feet wide and about 9 feet in length and have 2 people living in them. As we speak, all of the Bay Area is experiencing a surge in coronaviruses. And inside San Quentin, the fastest growing surge has grown to over 1,100 already. When I speak to my loved ones on the inside, I hear physical distancing is impossible. The medical alarms are going off every 10 minutes. People, including hospital workers who are cleaning COVID-infected cells, are being denied showers. They have not been issued hand sanitizer since March. Medical staff refuses to give them any updates on the outbreak, and they are scared. They say moving them from one highly overcrowded prison to another is not the answer. The only safe, responsible solution is large-scale releases. But in spite of reports to the contrary, releases have actually slowed down. Since beginning a modified program in March, earning time off of prison sentences through rehabilitative programming has been halted. In preparing these remarks, I have not been able to stop thinking about my friend Freddie Cole. He's 79 years old, and there were times in 2019 we didn't think he'd survive the year because he'd had open heart surgery and his meds were adjusted several times. I never once heard him complain, but when I spoke to him in the beginning of June, just as the outbreak was beginning, I heard terror in his voice. My dear friend, Daryl Galt, 66, found out earlier this year that his cancer has returned and he will likely not live out the year. This week, I found out he was one of the many who tested positive. I'm thinking of Lonnie Morris, 68, a friend who has mentored hundreds of others, both incarcerated and staff in his 42 years in prison. He created self-help programming that has prepared thousands of people for release. And I'm thinking of Patricia Wright at CIW, who's 69 and in chemotherapy with less than 6 months to live also. I say, with all due respect, that none of these individuals I'm naming, who are all serving sentences for violent felonies, are a threat to public safety today. And each of these people, like scores of others we hear from, have families they can return to immediately. In response to the outbreak, San Quentin has moved hundreds of people to the whole or an outside hospital. And the families of Tommy Wickard, Demetrius McGee, Juan Carlos Mesa, Miguel Cifuentes, and too many others do not know their status or exact location. When families try to get information on the health status of their loved one, staff is not returning emails or answering phone calls. From people inside, I hear that placing them in the hole for being sick is not the answer. When they are moved, their property is placed in storage and they're given a sheet, a blanket, and a bar of soap. The cells they are being placed in are dirty, and in their rush to pack everything up, guards are losing what few family mementos and personal items people inside are allowed. And I appreciate this committee's highlighting of CDCR's continued partnership with ICE. CDCR is the primary source of new bookings for ICE facilities, where 1 in 3 people tested by ICE have been found positive for the virus. At San Quentin, one of the worst outbreaks is occurring on death row, where family members of loved ones sounded the alarm at a recent town hall. Sanitation is not being properly attended to, and staff were working overtime in their area after working other sections of the prison. It's heartbreaking. And the response is to set up 6 tents and create a modest plan to release people, not based upon who is most vulnerable. It's not based upon prioritizing the elderly. It's not even based upon the CDCR's comprehensive risk assessment of who is least likely to commit violence or recidivate. Instead, they have a plan that's based upon the crime a person committed, even if it were 20, 30, or 40 years ago, and the fact that a person happens to have a release date soon. It's obvious that the CDCR does not understand the real threat here. I was excited that Senator McGuire is convening an all-hands-on-deck meeting tonight, and I want to offer myself as well as other advocates as a resource to share reentry resources. I would love to attend tonight. I'm thankful Secretary Diaz has created a new unified command center, and I would refer to that team the June 15 urgent memo by Berkeley health officials that said if the incarceration numbers at San Quentin are not reduced by at least 50%, the outbreak will overwhelm the entire Bay Area. This outbreak at San Quentin, like the ones at Corcoran, CIW, and CCC, are attributed to human error. But those of us who have spent time at San Quentin know the outbreak was inevitable because the CDCR's COVID response plan is insufficient and fundamentally flawed. Until we come to terms with the fact that large-scale releases are necessary for the safety, not just of those inside, but the entire state, this problem will not go away, and both incarcerated and non-incarcerated people will die. Thank you.
Mr. King, thank you very much for your heartfelt and accurate remarks. Now we will hear from Glenn Staley, who is the president of our California Correctional Peace Officers Association, one of the staff organizations representing staff at our CDCR facilities, actually the largest. Go ahead, Mr. Staley.
Thank you. Good morning, Madam Chair and members. Glenn Staley, CCPOA State President. I'm blessed to represent 30,000 of the hardest working men and women in corrections and parole. I'd like to start off by stating how much I appreciate you holding this very important hearing this morning. Like the rest of the world, it's been difficult times for our members. Our experience has been extremely challenging as circumstances are ever changing, yet we are doing our best to promptly adapt by making sure our members have necessary information, PPE, and anything else that they may need to continue to feel safe and providing an essential service to the state of California. This has been a hellacious experience for our members, as it has taken a certain level of bravery and courage to do the work we do every day, and as we've seen COVID-19 takes its course over time. We witness stress levels, anxiety, fear, increase amongst our ranks. These conditions are naturally associated with our job duties, but the fear specifically derives from the worry of bringing this disease home to our families and loved ones. As a result, this association took a preemptive measure to be proactive in keeping the members safe. In its early onset, the media, CDCR, and CHCS was releasing information that was not always perfectly aligned. This conflicting information led to our members to be unsure of the vital factors such as whether or not COVID-19 was an airborne or droplet transmission, how long the virus lasts, whether or not mass protection was necessary, time needed to be quarantined, and the most suitable way to social distance in a prison setting. As an example of the discrepant information, we've had multiple facilities attempting to address a number of issues, yet implementing the policy in varying ways, which has led to dysfunction and outright failure in most cases. While we do appreciate the fact that we can call Secretary Diaz and his management team to address certain policy, I also like to stress the fact that more needs to be done. In conclusion, we want our members to have a safe work environment. This requires a better decision-making from the department, particularly when it comes to transfers. There has been misconception that we believe COVID-19 is nothing more than a hoax or some made-up conspiracy. I want to make a very strong statement that says that's not the case. We have spent over $1 million on PPE for our members and their families. I, and along with my executive council members, board of directors, drove up and down the state of California to personally deliver protective equipment in 3 different waves. I'm glad to hear the receivership and Secretary Diaz acknowledge that our officers have been wearing the mask, and to say otherwise is a miscalculation and, quite frankly, insulting. In my 25 years as a correctional officer, there's never been a time where, on the whole, the officer and the inmates have both shared the common thread. The health and wellness of our officers is our top priority, but we need to ensure the well-being of everyone in the institution. We look forward to working with the legislators and to reconcile these issues, and with that, I'll be happy to take any questions.
Thank you, Mr. Sears. I think we'll hear from the doctor, and then I'm sure some members will have questions. Mr. Staley, sorry. Appreciate your participation and your testimony. Let us go now to Dr. Sears, who is, as I mentioned, a UCSF doctor and part of the group called Amend, and who was asked by the receiver to go into San Quentin. And I believe it was on mid-June, they released their report, their observations and their recommendations. So, Dr. Sears.
Madam Chair and members of the committee, thank you for inviting me to make a statement on the tragedy that is unfolding at San Quentin State Prison. I would like to emphasize that what I believe the committee already understands, and that's that we will not be able to control COVID-19 in California until we address what is happening inside prisons and jails. I'm here as a representative of AMEND at UCSF. AMEND's COVID in California prisons program comprises academics and health professionals with expertise in infectious diseases, geriatrics, public health, health systems, and epidemiology from UCSF and UC Berkeley. We visited San Quentin on June 13th at the request of the Federal Receiver's Office. At the time, their known case count was 16. Based on our visit and how the outbreak has evolved since then, we make the following primary recommendations to the committee for how to ensure that the public health response to COVID-19 in prisons is commensurate to the grave threat that it poses. First, develop a centralized COVID-19 outbreak emergency response team. I will say that I'm pleased to hear that this is urgently being created, and I have specific recommendations for the team. This team should have the authority to make public health-based decisions in the institution and should work in the facility during an outbreak. Prison leaders in any prison need outside expertise to respond to an outbreak. Prisons with outbreaks need a dedicated, experienced, full-time team with knowledge of correctional health and specific expertise. In order to address specific vulnerabilities that have been found, this team should include the following positions. Number one, an environment of care lead who optimizes ventilation, sanitation, and patient flow in the prison to mitigate COVID-19 spread through evidence-based infection control practices. Number two, a healthcare custody coordination lead who partners with custody to assess on a daily basis the housing of residents for medical isolation and quarantine at the discretion of the medical leadership. Number three, a COVID testing lead to coordinate testing of all residents, healthcare staff, and custody, and who ensures rapid testing turnaround time. Number four, a staff healthcare liaison lead to cohort staff and train them in appropriate PPE use and infection control measures. And number five, an epidemiologist analyst who tracks and reviews line listing of active and resolved cases. Our second recommendation is that we need urgent decarceration to address overcrowding. This is particularly critical at San Quentin and any prison that preferentially houses aging and medically complex patients, such as the California Medical Facility and the California Healthcare Facility. Our report recommends that the prison population at San Quentin be urgently reduced to at least 50% of the current capacity. Frankly, it's hard to understand how residents and staff can safely continue living and working in San Quentin at all. That said, while San Quentin may have unique vulnerabilities, decarceration is foundational to COVID-19 mitigation in any prison. All remaining recommendations are absolutely dependent upon decarceration for your success. I really encourage the committee members, every time you hear the words cohorting, isolation, quarantine, all of that should lead to you thinking the question of how, and how to do that involves decarceration. Quarantine and isolation of patients at San Quentin in any prison is like a delicate game of chess. And California prisons are already over 100% capacity, and every square on that chessboard has one or two pieces already on it. This makes the strategic movement of residents nearly impossible. As a result, we must depopulate all of our prisons immediately if we were to have any hope of avoiding what has happened at San Quentin and California's other facilities. The foundation of COVID-19 mitigation in the community is physical distancing and testing to isolate cases and quarantine exposed people. None of these community standard public health measures can be accomplished without space. As a result, rapid decarceration throughout California prisons is an urgent public health measure to protect people who are incarcerated, correctional staff, and our communities. Our third recommendation is to immediately develop a plan to support, test, and protect facility staff who are just as vulnerable to infection and who may transmit COVID-19 both inside the prison and in the community. The current occupational health contract at San Quentin does not align with the staff needs during the COVID-19 pandemic. Consequently, California Department of Public Health testing recommendations, which we've heard some about today, for congregate settings during an outbreak, such as testing all staff every week, are not being followed. Additionally, officers and staff must be strictly cohorted to work only on specific housing units or other physical spaces with the same sets of residents to minimize the risk of spreading COVID-19 within the prison. So, to summarize, what can be done now at San Quentin and at prisons across the state? Number one, immediately convene this COVID-19 outbreak emergency response team with the staffing that I've described. Two, immediately and significantly reduce the prison population through decarceration. Number three, immediately improve measures to test, cohort, and protect officers and staff. I'd like to close by describing what was really a haunting experience as we left San Quentin that afternoon. Men were pleading behind locked doors for help. And I still frequently hear them shouting, please, please, please help us. I can still remember the look of foreboding on the faces of the officers that could not be hidden behind their masks. I can only imagine the physical and emotional toll the outbreak at San Quentin will take on the correctional and healthcare staff working there, and most importantly on the residents and their families that are subject to these dangerous conditions. Our team at Amend firmly believes that prisons are a reflection of who we are as a society. It is incumbent upon all of us to respond immediately and proactively to address this tragedy, to prevent it from unfolding again and again around the state. San Quentin was not the first prison to be tested by COVID-19, and unfortunately it won't be the last. Please continue to call on our group at Amend if we can be of assistance. Thank you, and I'm happy to take questions.
Thank you, Dr. Sears. Let me see if any of my colleagues have questions. Go ahead, Senator Mitchell.
The testimony was quite compelling. I'm wondering, and maybe it's really a question of you, Madam Chair, what we can do to encourage, require the kind of task force that Dr. Sears delineated in his list of things to do. It was number one. Second, of course, additional release. So yeah, I don't know if that's, what can we do to try to effectuate that?
Senator Mitchell, I think that's a very good question, and I think a number of us, while obviously in your letters to from JBLC, you did not specify what you think should be in their plan, but you have been asking for a plan for all this time, and we didn't get one yet. Now, in the letters I sent, I did talk about release because of just the knowledge of that we know that to contain the disease, you have to have appropriate physical distancing, and that was not going to be able to be achieved in many of our facilities, and especially those with dorm-like settings. And if you think about the facilities that had initially the worst outbreaks, they were those with that type of setting. So I know that an incident command, what we all know because Dr. Ghali described to us, is going to be set up. We could consider whether it's our committee or whether even JBLC were to write a letter that that specifies some of these things that we think might need to be in this plan and that incident command should deal with.
I appreciate that, and I guess really and I don't fully expect you to have the answer, but I guess my point was writing letters hasn't gotten us anywhere.
You're right. But yes, which is part of
and
the
I'm
purpose
just
of the
wondering if
good point.
If it's I'm thinking out loud, which you probably shouldn't do in a public hearing, Madam Chairwoman.
No,
but
it's okay.
At this point, I think letters are no longer the answer.
Right. You're right.
And so, and I agree. And there's been I have been a part of conversations with you and the Secretary that have pushed the issue of release, where you have repeatedly reminded us all that the releases that have happened are releases that would have happened. Yes. I appreciate the focus on San Quentin, appropriately so, but we've also heard from Mr. Kelso about, the system-wide nature. And so as I understood Dr. Sears' suggestion, it really isn't, it is a, strike team, for the lack of a better word, to deal with the system-wide pandemic, internal pandemic. And so perhaps you and I can have conversation offline, talk to leadership to figure out what next the legislature can do to communicate our expectations. Thank you.
No, I appreciate that, and I appreciate your pointing out once again, and Dr. Sears pointing out once again, as I did at the beginning of the hearing, that yes, our eyes are focused on San Quentin. However, and you know, we're happy to hear of the containment at Lancaster and such, but just the nature of our facilities, this could happen to any one of them. And so this must be dealt with as a system-wide. It cannot be solely and only for San Quentin. So I totally agree with you. The other thing I would just raise, and you know, we're going to debate once again because our public safety trailer bill is still, was not passed by the second house yet. The legislature has in statute right now medical and elderly parole. And now, when it was designed, it wasn't, I don't think we necessarily thought of it in relationship to a pandemic like this. I think that, you know, people had different motivations, obviously, but part of the thinking at the time that it was developed was the fact that our prison costs, our budget for CDCR was going up exponentially, and largely due to these large healthcare costs of these very medically fragile people and very elderly people. It just is in the rest of the population. And so there was the feeling that if we could not just expand, we had no medical and elderly parole until that statute was passed. Now, you know, I've now asked for data. But since that statute's been passed, there have been very, very few people released, paroled under those statutes. And here we are in this pandemic. That statute is still available to CDCR. And yet, when I asked Secretary Diaz about it explicitly approximately a month ago, he described to me that 78 people were recommended. But when I asked him for the time period, he said it was 78 that were recommended back in 2018, and none since. But that those 78 who were recommended back in 2018, very few were actually successful once before the parole board. And I think it's very important for people to understand that the medical and elderly parole doesn't just let people be released. They still have to go before the parole board, and the parole board's not even acting. But it's still a tool. So I don't mean to describe it as, it's a tool that if there's a will, there's a way. And certainly, given that we know that the death rate is higher for medically fragile and elderly people, then it only makes sense for us to use this, for the department and the administration to use the statutory tools that we have given them. I would also just point out, and I'm sorry I'm taking up the public's time because I want to get to them, but I would also point out that, you know, it's costing us right now a minimum of $80,000 per incarcerated individual to house them. And if we were to do depopulation because of this urgent public health crisis, our cost for housing them elsewhere would be far less, far less. And we also heard at various times about staffing shortages, which surprised me, because we have a very healthy number of staff in our prison system, in our CDCR system. But if in fact there are staffing shortages, then what better time to utilize these tools we have, decrease our costs, increase the public health of everyone, and figure out housing in a different setting. So all of those things I think are essential, but I totally agree with you, Senator Mitchell. Letters alone, not enough. Hopefully, and I don't mean just hopefully, I'm brokenhearted about all of it. And I feel for the staff, as I said in my opening statement, that staff, the anxiety they must feel, and the families of the incarcerated individuals and the incarcerated individuals, all of us feel so much anxiety about this pandemic around would we get it, and the limitations on all of us. And imagine in those type of settings. And the only other, I guess I'll ask this question instead of just stating it, but if the if any of the panelists want to answer this, what I understand, and Mr. Kelso and the Secretary described this, that the incarcerated individuals, they can choose not to be tested. So, of course, some people wonder why. Why would they not want to be tested? So what I want to know is, if you are tested, so for example in San Quentin, and you are positive, then what happens? And I've heard some reports of what your circumstance you're put in, and that may be contributing to people choosing not to be tested. But I would appreciate if there was any of the people in the last panel who could answer that question for us. So that could be either Mr. Lewis, Mr. King, or Mr. Staley, or Dr. Sears.
Thank you, Madam Chair. So I know in 3 of the institutions that tested positive where I received phone calls, what happened is if you tested positive, you would be quarantined in your cell. Medical would come in if you had symptoms. They would put on their hazmat suits, test, and then you'd be quarantined. You and your cell, if you had a cell, would be quarantined to your cell. And then when the test results came back, if they remained positive, you will remain quarantined for the 14 days. If you did not test positive, then quarantine sign will be taken down. I also want to just share something else with you in the committee. There are 150 people right now, I believe, if my numbers still are correct, that are pending in court 1170D releases. I know Mike Romano and the 3 Strikes Project has recruited 50 attorneys to help move these people forward. But again, this is one of the things we've asked the governor. How about the power of commutation? They've already been given like high standards from the warden and everybody down at these institutions. I know it's not a large number, but that's 150 people that literally the institutions are saying these people are good to go. They're not a threat to public safety. And the only thing that stopped them are district attorneys in these different counties that want to put up a fight when a person shouldn't even be in prison anymore.
Thank you, Mr. King. I do understand from families of incarcerated individuals that many of those who are incarcerated have seen that those people, some people being tested positive are put in solitary and such, and have a lot of fear about that. So it could, all the things you described and much more could be contributing to why folks are not being willing to be tested. I have a question now for Mr. Staley, our president of CCPOA. You described having to buy equipment or buy masks. Does CCPOA feel that their staff are being given proper PPE, proper protective equipment?
Thank you. Well, that's a good question. In the beginning of this COVID, we had great concerns about the PPE getting passed out to our membership, and we immediately took the stance that we needed to protect and defend our families. So at that time, we purchased the N95 masks. Then we went out and purchased the cloth barrier masks for our members and their families. And then we bought the neoprene N95 reusable, and we passed that out. We just felt as an organization that as a family, our brothers and sisters deserved everything, and we felt like we could get it out quick, fast, and give them the protection they needed to come to work every day under these circumstances.
I think the legislature will appreciate knowing if at any point there is the sense that there's not being adequate protective equipment being distributed, because clearly that protective equipment is not only essential for the staff, but essential for the incarcerated individuals, so that everyone, so we can, again, contain this disease. So I appreciate if you fill us in. I have one last question for Dr. Sears, and then I want to move on to the public. Dr. Sears, you not only mentioned to us right now in this hearing these specifics that you feel should be followed. I know you also outlined them in the letter that you gave to Mr. Kelso and to the department. I'm wondering, have you or anyone else from Amend been invited to be part of this incident command or in any way to be advisory to, if not the entire system, at least San Quentin?
Thank you, Madam Chair. We have not been specifically invited to the Incident Command Center, but we have been in frequent contact with the receiver's office about continuing to provide ongoing support for CCHCS, the healthcare system within CDCR. We're happy to provide that support and happy to play any role necessary to help with the centralized leadership response, and particularly at San Quentin as well.
Well, thank you for that information. We'll try to, we know that whatever plan has got to be directed by competent medical professionals, public health professionals, so that is certainly something that we are going to be looking to as we see it get developed. Now I'd like to move to public comment, and I want to just open with, we set up certain panels, and we knew we had this hard stop, so we weren't necessarily able to include, for example, reps from all the staff organizations within our CDCR or some other core key folks. So what I've done is allowed a few people, including Karen Franklin from SEIU, Dr. Navreet Mann, who is with AFSCME Local 206, the physicians that provide care through CDCR, and a couple of others to speak for no more than 2 minutes each on the host line, and then we will move to the public line. So let's start with Karen Franklin from SEIU. Moderator.
Good afternoon.
Yes, please go ahead.
Good afternoon. Thank you. Good afternoon, Madam Chair and members of the committee. Thank you for the opportunity to comment. My name is Karen Franklin, and I work at San Quentin State Prison as a licensed vocational nurse, doing everything physically possible to make sure that our inmate population receives access to care. I'm also a proud member of SEIU Local 1000. I would like to briefly comment on what it is like working at San Quentin State Prison during the COVID-19 pandemic, as well as other state prisons, as I have been in constant communication with nurses across the state. Access to PPE within San Quentin State Prison, as well as other prisons, has been widely very dismal at best. Through this crisis, our request for PPE to management has fallen on deaf ears. We have been forced to reuse gowns, masks over and over until they have become tattered. We have also had to resolve to using garbage bags as gowns and half-ounce ponchos purchased online to try to protect ourselves. Nurses are retrieving their used N95 masks out of the hazmat bags and cleaning them with Clorox wipes to reuse them because they were unable to find a new one in their institutions. This is devastating as we are frontline hands-on with our COVID plus patients. I can say that within the past week, access to proper PPE at San Quentin has improved very much due to a collaboration of many different people in which we are very grateful for. Our staff are being put into a seriously dangerous practice of being mandated and drafted to work additional shifts day after day until we are physically and emotionally exhausted. We sleep in our cars because we know that we are not in a condition to safely drive home. When we inform the supervisors of our exhaustion and feeling unable to safely work another shift, we are threatened with adverse actions. We need help now, please. Every day I see more and more of our staff testing positive for COVID-19, even though we personally try our best to protect ourselves. It does not feel like the department has done what is needed to protect us. CDCR and CCHCS continues to move inmates around, as recently attempted this past weekend from San Quentin, exposing staff and other inmate patients unnecessarily. This needs to stop. They should be sheltered in place until we can control the outbreak. Please stop exposing all of us unnecessarily. We must do better. I commend all for their dedication, but the induction of support in the form of outside resources is critically needed right now. Thank you very much.
Thank you, Ms. Franklin. Now, Dr. Mann.
I'm being told that Dr. Bussey is speaking in place of Dr. Mann.
Okay, that's fine.
Your line is now unmuted.
Okay, go ahead.
Okay, thank you very much, Dr. Skinner and Dr. Mitchell and the rest of the panel for letting me speak. I'm Dr. Stuart Bussey. I'm a family physician and attorney, and I've been the president of the Union of American Physicians and Dentists. We have about 547 doctors and psychiatrists, a couple hundred dentists, and of course, San Quentin, the tragedy that's happened there is really, as the other panelists said, really a question of failure to communicate, as they said, and also minimizing the medical voice, which Dr. Sears alluded to a few minutes ago. This is a pandemic, and we've seen in the rest of this country, when the nursing homes spread out, that it wasn't the political minds or the bureaucratic minds that fixed it. It was the medical decision-making, the epidemiologists that separated people and had less contact, social distancing, not more. So we would like to take up what Dr. Sears and the other panelists have mentioned as far as being an integral part of fixing this problem. Our members are on the ground, exposed like the CCPOA and the SEIU members, and we all need a voice at the table. We all need to take charge here and be listened to actively, not just written up as our members in March were for complaining about PPE, or in Chino, CIM, when we noticed there were too many rounds going on, but also to make comments on the entire panorama of what has happened here. It has come to my attention that the 500 inmates that were transferred originally in May, that the reason this was to improve the access for the MAT program, the ISU-DT program, which was a politically motivated program that costs hundreds of millions of dollars to the taxpayer and is an unproven, that is rolled out the use of Suboxone. Now, we know that the reason for the transfer was in a large part due to the inability of the reception centers to take care of these, this addiction program. So that's why they were sent out to the main lines like San Quentin. This caused an unexpected problem when the transfer occurred with people who weren't tested right immediately before the transfer. We already know that. So when you look at the whole way that the CDCR is run, we want medical input. We would have liked to have had the decision on, what the issue is in the MAT program, the drug addiction program, why the transfer started in the first place, and now look what's happened. So that's my message here. We need input not only on when the emergencies and the wildfires occur, but what causes the wildfires. And when we don't have input onto an unproven program like the MAT program, the unexpected consequences occur.
Thank you.
Thank you for your time.
Thank you, Dr. Bussey. Thank you. Now we move on to Steve Fama from the Prison Law Office.
Pardon me?
Steve Fama from the Prison Law Office, correct?
No, I'm from California Attorneys for Criminal Justice.
This is Steve Fama from the Prison Law Office,
please,
Madam Chair. If you'd like me to speak,
yes,
I'm prepared to do so.
Yes, I would. Thank you. Go ahead.
Thank you. Good afternoon. The Prison Law Office is a private, not-for-profit group of attorneys and others that try to help people inside about what happens to them while inside. I've been there almost 35 years. In late March, when there was literally less than or only 2 or 3 cases, the state, including the governor, were presented a sworn declaration from a nationally recognized prison public health expert that said that immediate population reduction was necessary to save lives, given the COVID-19 pandemic. The state, including the governor, said no. And in part, they said it's because we're planning to do early releases ourselves. But those early releases averaged only about 100 people per prison in institutions that average about 2,500 people each. In other words, it was almost not noticeable. And then those releases stopped. Since then, sadly, thousands have been infected, scores hospitalized, many of whom, by the way, even though they're listed as recovered, aren't the same health-wise. And most tragically of all, 22 people are now dead. About 2 weeks ago, the experts at the University of California, San Francisco, said that San Quentin needed to immediately have its populations reduced. That, again, did not happen. And we see now what has happened at that prison, with more than 1,000 infected, and as I checked this morning, more than 30 hospitalized, whom I pray and hope will all recover. We have, as has been mentioned by testimony earlier, other prisons where there are great numbers of people who are in danger from COVID-19, starting with the California Medical Facility in Vacaville, the mega medical facility in Stockton, and there are other prisons like San Quentin with old-style 5-tier cell blocks, such as Folsom with no solid doors, where people are going to be vulnerable. There is still time, and the state needs to take action to reduce the prison population, particularly the medically vulnerable. I would like to end with what I admit is a rhetorical question. Our Governor Newsom, has been a forceful leader in this state during the pandemic, with the daily briefings and the bold action to protect the public in general. But where has the governor been for the people in prison? Thank you very much, Madam Chair.
Thank you, Mr. Fama. We're going to go to Brendan Woods next, then Stephen Munkelt, and after that, we're going to go to the folks who are here in this room. So please, the remaining folks, those of you in the room, we're going to be a different time period. I'll announce that in a moment, but for the two people left to speak on the phone, please 2 minutes each so we can move on. Okay, Brendan Woods.
Brendan Woods is not currently on the audio, but Stephen Munkelt is.
Okay, then we'll go to Stephen Munkelt.
Thank you, Madam Chair, and I appreciate the opportunity to speak to you and the committee today on what is literally a matter of life and death for so many in our state. I am the Executive Director of California Attorneys for Criminal Justice, CACJ, and CACJ has prepared a list of requested actions, a proposal, which has been distributed to the administration as well as to the chair and members of this committee. We are encouraged by the strong comments and appropriate questions raised by the committee today to the members of the panels, and know that it reflects a deep-seated commitment to take strong and immediate action, not just at San Quentin, but at all state facilities. Our clients and their families have expressed significant and justifiable concern that insufficient steps have been taken to prevent the spread of COVID in carceral facilities in California, despite repeated calls to action, including some of those referenced in the committee today. In a slightly altered form or slightly reduced form, I'm going to try to emphasize the points, the proposals that we have made in the written documentation. And to complete my oral comments today, the numerical order of these proposals or suggestions does not have anything to do with their relative importance. Number one, establish new and independent oversight of CDCR facilities and local jails, where we also have carceral populations at risk in this disease, to ensure prompt compliance with any health and safety requirements, and to receive complaints about prison and jail health and safety conditions, and to take all necessary steps to prevent further spread. This will help identify if reported numbers are accurate and establish immediate and necessary steps to protect the health and safety of those still in those facilities. Number two, provide health services and testing to anyone released from a CDCR facility for the duration of the public health emergency. Number three, adjust the inmate population to match the actual rated capacity. This can be done by establishing protocols for those with less than 24 minutes left to serve and exploring transitional alternatives for those who are not serving a sentence for a violent offense.
If you could wrap up.
Okay. I'll defer in that case to the written proposals that we've made. Thank the committee for its important attention and oversight in this area, and encourage you to pursue proposals to dramatically reduce the carceral populations as the first step to solving this problem. Thank you.
Thank you. We welcome recommendations in writing because, of course, that helps us to do appropriate follow-up, since we, some of us are taking notes, obviously, but memory alone is, so we welcome suggestions in writing. Now, we're going to go to the folks who are here in this room, and then we are going to go to the alternate room, and then following that, we'll go to the phone lines. So moderator, you could queue up those on the phone lines. Now it's 12:28. We have a hard stop at 1 o'clock. So I would ask everyone else to go 1 minute or less so that we can hear from as many people as possible. And thank you very much for being patient and waiting. And go ahead. We can start with our first person who's here. Go ahead.
Okay, thank you, Madam Chair. My name is Bernard Moss, and I'm with the GRIP Training Institute. I'm formerly incarcerated, and I'm here to advocate for a segment of the population that's often forgotten when we talk about releasing safe people back into our communities. I'm here on behalf of lifers in prison here in California. My program is, over the last 8 years, graduated 913 human beings from our program. 321 of those individuals have gone before the Board of Prison Hearings. In 8 years, one of those individuals has returned back to prison for a non-violent offense. Okay, that's less than a 3% recidivism rate. We feel that we should, with our experience and our wisdom, be part of CDCR's strategy, not only now, but in the future, when it comes to releasing safe people. So we're asking that you look at lifers who have been involved in programming. They are safe, and they need to come home. And holding them in prison with this virus going on is just endangering their lives. I have a brother that's incarcerated. I have friends, family, loved ones that are all incarcerated. And it's time for these people to come home. They've served their time. They're doing the work to come home. And we don't come back to prison. I've served my last 14 years at San Quentin, so this issue is near and dear to my heart. And I don't want to see anyone die from this COVID-19 virus.
Thank you.
Thank you.
And thank you for staying and being with us this whole time.
Thank you. Appreciate
Let's hear
the time.
from our next public speaker.
Hello, and thank you. This is an unparalleled crisis. Immediate, drastic action must be taken. This is not a time for mitigation. COVID-19 is exploiting our weaknesses as a society. Our system of incarceration has a history drenched in unjust policy and inhumane standards. The plan created to address the spread of COVID-19 must also fundamentally change how the government rehabilitates people who have been convicted. Attempting to address the spread of COVID without dismantling the prison system as it is now would be gross negligence. COVID-19 will be a deadly threat until we have a vaccine, which is a year or more away from being widely available. You need to immediately release at least 75% of the incarcerated population. On June 15th, Chase, an inmate in California, wrote the following: "With 3 months to go on my sentence, the coronavirus has made it in with 15 confirmed cases and more to come. So we are just sitting ducks in here now. Immediate mass release is the only ethical action. Anything less amounts to mass execution by biological weapon." Thank you.
Thank you. Next public speaker.
Thank you, Madam Chair and esteemed committee members. My name is Miguel Garcia. I'm a policy coordinator with the Anti-Recidivism Coalition. We provide services inside the institution. I want to go ahead and start off with sharing some insight from Alejandro Rosas from Lancaster State Prison. He's part of the PIA Laundry, and he wanted to take recognition in taking pride of the work of helping out the veteran hospital, of decontaminating some of the blankets and other sheets that are possibly contaminated with COVID-19. I also would like to echo the concerns that many of the individuals have with correctional officers searching their rooms and not sure what products may have been touched or who or what is going through going past the phases of before correctional officers enter the facility. It's very scary for them. One individual said that he had symptoms including coughing, chills, fever, and breathing problems. He reported to work, and within the first 10 minutes, his clothing was soaked wet with sweat. He had never been sick in his whole life. He was quarantined and given something like Tylenol. A day or so after, he was given Thermaflu. He slept for the next few days. He remembered telling himself that he was going to die. Again, I appreciate the committee and the esteemed guests for providing services. Thank you.
Thank you. Next speaker.
Hello, I am here as a family member directly impacted by mass incarceration and extreme sentencing. The last time I heard anything about my family member inside was about a week ago. I don't know if they're safe, if they are well, if they're going to live. Prior to that, I had heard about all of the insufficient ways that this system has been dealing with this pandemic. Lack of masks for the prisoners and the correctional officers not wearing them. Lack of hand sanitizer, access to basic needs like soap and shower. And just an overall cavalier approach to what is going to be an extreme human rights health crisis if not acted upon now. We demand that transfers stop, that early releases are granted, that inmates have basic access to needs and care, and that outside medical organizations and experts are tapped to come in and aid with the overflow that is impacting the system, surrounding communities, and more. This is bigger. This is bigger than politics. This is real lives, real families, and I want to know that everything is being done so that I do not get a call that my family member has died.
Thank you.
Hello, my name is Sierra, and I thank you for giving me the time to speak today and also focusing on the much-needed action that does need to be taken on this issue. I ask that you take immediate action on the astronomical spread of COVID-19 within CDCR, specifically San Quentin State Prison. I ask that action is taken doing the right thing, and to be clear, taking action on the basic human rights of these incarcerated individuals. The circumstances and living conditions that are happening right now is quite shameful. The experts, the medical professionals, are telling us that we need to decarcerate to 50% minimum to stop this system-wide issue. Why are we not mass releasing? Thank you.
Thank you. Next speaker. Oh, okay, so we go to the other room. So our auxiliary room, I think there's 6 or 7 people there. Can we start now with the speakers in that room? Go ahead.
Good morning. Can you hear me? See me?
Yes, yes, we can, and we can see and hear you.
Good morning. This is Brendan Woods, Public Defender of Alameda County. I drove up instead of being on the phone. So on June 3rd, I sent a letter to Governor Newsom and Secretary Diaz with 289 signatures of people incarcerated at San Quentin pleading for help. At that time, there was one positive person in San Quentin. On June 24th, I sent another letter focused on releases. And I gave them 3 simple suggestions. Number 1, immediately release people 1 year left to serve. We know that could possibly cause up to about 30,000 people to be released. Number 2, release the elderly and the vulnerable population. We know right now that there are over 5,000 people who are over the age of 65 in our prisons in California. Number 3, develop early release for people with 3 years left to serve. We know in our prisons that there are over 60,000 people that are considered to be low risk. Low risk, they're ready to return back to society. We cannot focus on violent or serious felony, but those who are able to return. And when we say release, we mean release not into ICE custody, not into another place where people be held in an unsafe environment. These are the minimum. This is the floor. Basic requests that we're asking for. Groups like Ella Baker Center, Restore Justice, Uncommon Law have a full set of recommendations that CDCR should be adopting now. On Friday afternoon, once we saw that the situation in San Quentin was getting out of control, we started a petition. From Friday afternoon till yesterday evening, we were able to sign up over 10,000 people demanding the governor and secretary take action now. And we need to take action. I represent people who are in prison. I've been to San Quentin frequently. I know these men. They're my friends. They're my mentors. They're kind. They're compassionate. They're intelligent human beings. And so we are here today, and we're asking you to see them. See them not just as inmates or prisoners, but see them as people. And treat them the same way you want to be treated or I want to be treated. We spent so much time and energy and money and focus on people out of custody, people in the community. I'm begging you, begging the governor, begging the secretary to now take that energy, time, and focus. It's long past due for us to focus on those people who are in custody. Please take action now. Thank you.
Thank you, Mr. Woods. And I gave him 2 minutes because he was supposed to be on the other line. So I didn't want people to think that we were being unfair to those of you who have been waiting. I just wanted to point out that I was going to mention earlier, but the LAO, our Legislative Analyst Office, has a report, and they themselves have given us data that there are tens of thousands of incarcerated individuals who have less than 1 year left to serve. Now, can we have our next public speaker? And again, we're going to hold to the 1 minute time limit.
Hi there, my name is Adrienne, and I'm here on behalf of my father, an inmate at San Quentin State Prison. There's no argument that the recent transfer was a miserable failure, and it's clear that the CDCR has not been doing everything in their power to protect these people. I understand that they have been trying, but if they cannot succeed, then they must release their prisoners. My dad is the most important person in my life. He's 63 years old, in remission from cancer. He has other underlying health issues, and he's at very high risk for getting sick and developing life-threatening symptoms. Please understand that COVID-19 is a death sentence for people like my dad and other at-risk inmates. No one will respond to my calls or emails regarding his well-being. I've been hung up on multiple times by the warden's office assistant because she simply has no information to give to me. It's terrible, it's unjust, and I'm heartbroken from it, honestly. I'm calling on Governor Newsom to use his power and order mass releases immediately and guarantee safe conditions from inmates across the state. Thank you.
Thank you. Next witness.
Thank you, Madam Chair, for giving me the opportunity to speak. My name is Isaiah Rodriguez, and I'm a concerned resident of the state of California. I have friends and family in the CDC, as well as I currently have a family relative in San Quentin State Prison. I believe that keeping elderly inmates inside of prisons at the time of this pandemic is a death sentence, and I believe that they need to be released immediately for their safety and for our conscience. I also believe that the populations of the prisons need to be drastically reduced immediately, along with the requests of multiple speakers today. And I don't believe that there is any more time to take on these issues. I think that every single day we take from this moment forward is 24 hours too long. Thank you very much for your time.
Thank you. Next witness, or rather public.
Hi, I'm reading a prepared statement by Larry Williams. My name is Larry Williams. My inmate number is C61205. I'm housed at San Quentin State Prison. I tested positive for COVID on June 11, and I was placed in isolation only 4 days later on June 15th, when I should have been transferred on June 11th when I tested positive. I believe that I caught COVID because I was an inmate worker at South Block in the Alpine Restriction Unit. I was working as a porter in the prison. On June 10th, me and 5 other inmates were instructed by prison guard Officer Wart to move hundreds of boxes up to the 5th and 4th tier outside of the wing in the hallway of South Block. We realized that we were moving the property of prisoners who were transferred from Chino. We asked about it. Officer Haley said, "I'm not touching or moving that property. If you guys don't move it, the inmate won't receive their property." We moved the boxes because we were afraid of losing our jobs. That night, I started getting sweats, coughing, and sores. I lost my appetite. They called me for tests the next morning, and I tested positive. In his statement, Secretary Diaz said that testing was being done on all inmates, including temperature testing. Larry told us they don't give us adequate supplies or materials. They don't even take our blood pressure anymore. They make us bend down, and instead of opening the door, they make us put our face to the tray slot where the food comes through.
If you could wrap
and then
up.
they do the temperature check. They don't even ask what our symptoms are. We don't have clean bedding. They shower us every other day, sometimes. They allow us to use the phone a lot, but outside of that, they're more mad that they lost staff than that they've infected all of us. Again, my name is Larry Williams. I'm out of San Quentin. I am not a violent offender, and I believe they should start releasing people like me.
Thank you.
I don't.
Next witness.
I'll be reading a statement from a prisoner in San Quentin. Hello, my name is Dejan Joy. CDCR refers to me as AN1011. Currently, I'm at San Quentin Prison in the gym area. I committed armed robbery and was sentenced to 18 years and 8 months. I have been in the gym since April 15th. 108 of us have been captive in the gym. We were forced into 8 pods. CDCR says that being 3 feet apart is okay because the distance is 6 feet apart diagonally if we sleep head to toe. Imagine that. That logic did not work. On June 29th, 2 individuals in the gym tested positive for COVID. Then 3 individuals were removed for experiencing symptoms. I try my best to social distance, but it's impossible in the prison setting. There are only 4 toilets for 107 individuals, 1 urinal for 107 individuals, 2 sinks for 107 individuals. I stand in line and am surrounded by people trying to use the restroom. We were supposed to use partitions to reduce the spread of the virus, but they have not been provided. Although I personally was not on the list to transfer to North Kern State Prison on Saturday, June 27th, I watched the associate warden try to send infected individuals to North Kern Prison, telling everyone who is being transferred has tested negative, which wasn't true.
Thank you. Apologies. We do have lots of people on the phone line, so if you could stick to 1 minute. Thank you. Go ahead.
Hello, my name is Richard Tan, and I'm speaking on behalf of the coalition that organized 2 previous car caravan demonstrations to San Quentin. Mr. King, Dr. Sears, and some of the prisoners who have spoken before me have explained that mass releases are the only real solution to this crisis. That is a solution that the speakers on the first panel, including Secretary Diaz, were unwilling or unable to consider. However, Governor Newsom has the power to resolve this crisis immediately. Under his emergency powers during the coronavirus state of emergency, he has the power to rewrite CDCR regulations, as well as commandeer private property, including hotels and medical facilities, to rehouse prisoners. He explicitly invoked these powers back in March, but in 3 months he has failed to invoke them on behalf of prisoners in California prisons. We demand that Governor Newsom order mass releases now, and that this committee take a public stance calling on the governor to do the same.
Thank you. Are there any okay, I see another person. Go ahead.
Yes, my name is C.T. Weber. I'm the Peace and Freedom Party of California Legislative Committee Chair. And, it's our understanding that the need for prison reform has been known for years. It's very unfortunate that it took a COVID-19 pandemic to expose these problems. Our prisons are overcrowded. Social distancing is impossible. We need to reduce the prison population. Over 1,100 cases are in San Quentin alone. Testing of all prisoners and staff should be required. Additional early releases, those over 65 releases, low-risk releases. Governor has the emergency powers to reduce the prison population by releasing selected populations. And then the legislature should follow up and pursue this matter on prison reform. Thank you.
Thank you. Is there another person in the room? All right, then we'll go to the phone lines. And it's 12:48. I will still leave 1 minute, but for those of you on the phone, if you do less time, then more people on the phone can speak. Go ahead, moderator.
On the phone lines, if you wish to have your, thank you. Ladies and gentlemen on the phone lines, if you wish to have your comments heard, please press 1 then 0 at this time. We do have a few that have already queued up. We're going to go to line number 259, 259. Your line is open.
Hello, can you hear me?
Yes, we can hear you.
Hello,
Proceed, we can hear you. So now we can't. Is your line?
I do apologize. I'm experiencing technical difficulties. I'm going to have one of my peers take over. One moment, please.
My apologies to those of you who have been waiting and are on the phone
Right.
lines. Go ahead.
Thank you. This is Tom. I'll take over from here. We will go to line 155. Please go ahead.
Hi, my husband is at CCC. The lack of contact has caused continued emotional distress. I am listed as the next of kin, but they will only contact me if he dies. I received a letter on the 29th, which I emailed to Senator Skinner. He wrote it on the 25th. He said no incarcerated workers are working due to a total lockdown, and the guards were responsible for all the cleaning and cooking. The guards were only wearing masks when higher-ranking officials were present. They were not cleaning the unit or showers after use, and the old food was on the floor. My husband told staff that he was almost out of toilet paper and had no soap, and what should he do? The guards laughed and told him to use his hands. He will be retaliated against by the guards due to me going public with this information, but we're taking that risk because this is not humane. There were also allegations I've heard that the food is being served on uncovered paper trays from the kitchen to the housing units. My husband is 18 months from a release date, pending his programming credits that I hope he still receives during this time. He spent all this time productively paying his debt to society, but due to CDCR's negligence during this crisis, he may not survive this outbreak.
Thank you. Thank you. Next phone line.
We will go to line 274. Please go ahead. Line 274, you are open.
Good afternoon, Madam Chair and members. Micah Doctoroff on behalf of the ACLU of California. We are deeply concerned by the governor and CDCR's failed response to COVID-19 despite months of alarm bells being sounded by incarcerated people and their loved ones, by public health experts, by litigators and advocates, by the press, and by other members of our communities up and down the state and across the country, all calling for increased emergency releases as the only way to save lives and avoid the disaster now upon us. We are particularly alarmed by the ways in which the state's failures reinforce and exacerbate the state's shameful history of systemic discrimination and devaluation of Black and Brown people, who are both disproportionately vulnerable to COVID-19 and disproportionately represented in state prison. We are also concerned that despite the COVID-19 pandemic now raging in immigrant detention centers in California, CDCR continues to voluntarily pipeline community members into detention rather than returning them to their families and loved ones to safely shelter in place. When CDCR identified vulnerable community members for accelerated release this spring, 78 of those community were transferred to ICE detention straight from one COVID-19 hotbed to another.
Thank you.
ICE has reported that nearly half of the new admissions. Thank you so much for your time.
Thank you. Next.
Line 281, you are now open.
This is Danica Rodarmel, the State Policy Director at the San Francisco Public Defender's Office and a person with a loved one incarcerated inside San Quentin. Over the last few years, the California legislature has done a lot of important work on criminal justice reform. However, so far the response to the virus in the prison population has exposed that many in leadership, while claiming to believe in criminal justice reform and decarceration, continue to act according to old guard politics instead of the most sound and humane public policy. With more than 50% of people in CDCR custody being assessed low risk of recidivism by CDCR's own measure, it's clear we can safely and dramatically reduce the prison population today. It's truly the only sufficient solution to this emergency, and releases should include lifers and not be made with categorical exceptions. It's time for us to get real about this crisis and the clear solution, to stop being afraid of the politics of the past, and to ensure that our actions match our words. Thank you.
Next speaker.
Next, we will go to line 236. Line 236, you are now open.
Thank you, Madam Chair. I respectfully comment as a San Quentin coworker, and I am a certified correctional health care professional. I have been a very vocal advocate through the COVID crisis. This advocacy comes from my personal knowledge, including many frightened midnight calls of my coworkers and my interactions with all of the San Quentin executives. I come with a prior military background, including disaster response management and addressing biological outbreaks similar to COVID. Negative comments have been noted. I want to highlight some good. If not for the leadership of Acting Warden Ron Broomfield, our San Quentin wildfire would be an ash pile. We are lucky to have him. And by the way, he's not in my chain of command. I additionally work with hospital administrators and outside health care. I've listened to the testimony. Respectfully, contracts for testing is not the issue. A 15-minute results, less invasive, FDA-approved test is available now, used elsewhere. The cost is about the same and is equally accurate. We could get a more real-time vision of our population and better compliance. I can't provide that product information via my lawmakers. I want the daily heroism of my colleagues, nurses, correctional officers, and doctors to be recognized. This was a failure, but not for our creation, and it was above the San Quentin level. Only through my coworkers' daily heroism. Thank you very much.
Thank you. And please submit anything you like in writing. It does help us. Next public speaker.
We'll now go to line number 262. Your line is open.
Hello, can you hear me?
Yes.
Great, thank you. My name is Roberto, and I live in Orange County. I just want to say, Secretary Diaz, you're pretty trashy for relying on your policy to continue transferring folks to ICE custody. We're adamantly against this in Southern California, so you need to change your policy about transferring folks over to ICE, and you need to start freeing everyone. I need you to call on Governor Newsom to close down immigrant prisons in our state because COVID is rapidly spreading in those areas. So yeah, you're just pretty trashy. Thank you.
Next speaker.
Next speaker will come from line number 290. Your line is open.
Hello, Chair and members. Benjamin Tran with the California Pan-Ethnic Health Network. All Latino and Black community members have historically been discriminated against in our criminal justice system and are disproportionately being impacted by this pandemic. In prisons and ICE detention centers, precautions necessary to our overall success of combating the virus have been thrown out. You've heard today how prisons, by design, keep people in close quarters and make social distancing impossible. Prisons have become a petri dish time bomb of COVID-19. There have been attempts to hide the problem. The Bear Institute of Justice estimates that the actual number of positive cases could be 15 times higher than the figures reported by ICE as of mid-May. We must take actions because without proactive steps in a potential second wave of COVID-19 looming, we are setting ourselves up for failure. CPEN would like to thank the committee for convening today and bringing these issues to light and encourage the governor to adopt policies aligned with the latest health science. Thank you so much.
Thank you. Next.
We'll now go to line number 300. Your line is open.
Three, 300. Do you have your line on mute? Moderator, perhaps we can go back to that person and you can go to someone else.
All right, we'll go to line number 313. Your line is open.
Hello, my name is Abigail Ramirez with LCHC. Incarceration and immigration detention is a public health crisis, and the pandemic has made that more urgently and acutely true than ever. These institutions systematically deprive immigrants and systems impacted individuals of liberty and have a long record of medical neglect. We support the efforts to establish the COVID-19 emergency health response team previously mentioned, provide rapid testing turnaround and appropriate healthcare training to staff. Specifically recommend immediate mass release of people in prison amid COVID-19, increase access and adequate PPE for all systems impacted individuals and staff, stop the transfers of people being released from state prison to ICE, and the immediate release of all individuals in ICE detention centers. Thank you.
Thank you. Next speaker.
We're now going to line number 173. Your line is open.
So my name is Gabriela and I live in Oakland. I demand the CDCR and Governor Newsom to grant mass releases in order to reduce the California prison population and protect people who are incarcerated. As COVID-19 spreads throughout our prison system, thousands face potential long-term complications or death. It is impossible to assure the safety and maintain the social distancing of people who are incarcerated in our overcrowded California prisons that are at 190% capacity. Our criminal justice system disproportionately impacts the same communities that COVID-19 disproportionately harms, including working class Black and brown people, people with intellectual disability, undocumented peoples, and the unhoused. We have an ethical obligation to grant mass releases. The lives lost to the uncontrolled spread of the virus in our prisons is due to the state's perpetuation of mass incarceration and current inaction to secure the basic human dignity for all of your constituents. Grant the mass releases to reduce the state-induced density of our prisons. Ensure CDCR follows mitigating actions supported by public health experts with measurable accountability systems that are beyond self-referral. And stop CDCR policy regarding ICE transfers.
Thank you.
It's just unethical. I yield my time.
Thank you. Next speaker.
We'll go to line number 35. Your line is open.
Yes, hi. Thank you for this opportunity to share my comment, and thank you, Senator Skinner, for putting this committee together. I've heard folks mention Governor Newsom and reaching out to Governor Newsom, but I would like to express my concerns because he has displayed his, unfortunately, an uninterest and in our incarcerated population. So it seems that this should be made a priority to the folks that are here present. And I hope that I encourage that you guys hear everything that is being shared and presented today. I hear a lot of talk of analysis and, numbers and plans that look good on paper, but the protocols obviously have not been followed accordingly, and this follow-through has led to where we are today. I respect all the efforts that have been made.
Thank you.
However, it is evident that it has not been enough. So I encourage that
We are going to our last two.
all that has been taken.
Thank you. Apologies.
All right, go.
We are going
Thank
to
you.
our last two public testimony since we've reached our time limit. We can have two more and then we must end. Go ahead, moderator, give us our last two.
Line number 190, 190, your line is open.
Thank you. Hi, my name is Dr. Kat Slusser, and I am a PhD prepared registered nurse. I'm also calling in because my loved one is currently at San Quentin. So it is obvious that decarceration and mass releases is one of the top priorities that desperately needs to happen now. CDCR has already initiated early releases for inmates that have 180 days left on their sentence. However, out of the current population of roughly 3,500 inmates at San Quentin, officials were only able to identify 40 inmates that qualified to be released early. I highly encourage you to expand the early releases to at least 365 days. According to the Marshall Project, the federal prison system is already releasing prisoners who have 18 months left. So why can't CDCR expand early releases to at least 12 months? In addition, the other previously established early release programs also need to be expedited. We have the alternative custody program, which typically takes 4 to 6 months to process. That could be expedited. Another example is Prop 57, nonviolent early parole, and that takes 6 months.
Thank you.
Thank you.
And now we'll go to our last public speaker.
We'll now go to line number 272, your line is open.
Yes, hello. I would like to thank you for allowing me this time to speak. Thank you for Senator Skinner for putting this together, and not only for addressing this, but also to bring accountability to Secretary Diaz and Dr. Kelso. My name is Missy Hart. I am advocating both as a formerly incarcerated person and as a citizen for the people who are incarcerated, not just the people. I want to echo what everyone else has been saying, that there needs to be a lot of immediate releases, but we also really need to include lifers, and we need to listen to the people who are incarcerated right now. If you're not familiar, there is a lot of demands going out there, since the visits have been suspended. There needs to be some other way to support inmates who are incarcerated right now in many ways, also addressing their mental health concerns. As someone who has been put in isolation and solitary confinement many times, it is detrimental to their mental health, and we also need to put in concerns of that. We can't just lock people up. We can't just put people in the open beds. We need to use that funding to house people once they leave. Over 40% of people who have been released, they have nowhere else to go. They're just going from one situation to a bad situation. And I also want to echo, we need to stop with the relationship with the ICE, with sending people to ICE. If we're really going to make some changes,
Thank you. I know that there were many, many more people who wanted to speak, and I am deeply sorry that we have this hard stop. I know that all of my committee members wanted to hear from you, and we know that you represent loved ones and family members inside our facilities. You may be staff yourselves or represent staff, or you just may be concerned Californians. And my apologies that we could not hear from you all. We welcome your letters. We have received many. My office alone has, I don't know the exact number, but we've received many, many, many emails and letters. We welcome those. And if you have specific recommendations, we welcome those. This was obviously a very important hearing. I share with Senator Mitchell not sure about how we can make sure that what was discussed today actually gets pursued, and we'll have to think more about that, but I certainly hope that the administration and CDCR has heard loud and clear the concerns by the medical professionals, by the legislature, by the community, and so many others. So I want to thank all of the committee members who hung in there, and all that participated, and the staff for helping us put this hearing on, all the staff, committee staff, and floor staff. And then for the panelists that joined us, I really appreciate your time. And I do not want this to be just talk. I want to see action as a result. The entire state deserves that, is entitled to that, and we will feel the appropriate respect once we see the action. And with that, I will conclude this hearing.